So Leon, just let me know when you want.
Perhaps it'd be quite nice to ask people to say where they're from in the world when they're joining. Be nice to know where everyone's from.
Yeah, you should do. You should do that as part. As again, I think that I
Yeah,
assume you're going to do a housekeeping anyway, so maybe that's part of that.
yeah.
Indeed, it is, yes.
Hmm.
We've got a few more attending. Morning, everyone. I think that's Sam, isn't it? There, yeah, that's Sam. Sam Willis is here now.
Hello.
Hi, Sam. How you
Hi, how
doing?
are you?
I'm fine, thank you. Welcome.
Thanks.
Welcome to Gibraltar.
I feel like I'm teleported to Gibraltar.
What time is it there where you are?
10 to 5 p.m.
5 p.m.
Ooh.
That's good. That's good.
I'm a
Oh,
bit early.
That's fine.
I saw the email saying it's starting, so I just thought I'd pop in and see what's going on.
Yeah, we're just going to have a bit of housekeeping and a welcome from our
Oh,
Vice Chancellor in a minute.
oh, okay. I'm interrupting. Sorry.
So we've got
no.
Stefania from the University of Brighton. Someone just said
From
hi
from Birmingham.
from Birmingham. Oh, University of
Yeah.
Brighton, but she
Yeah.
hi from Birmingham. Yeah.
Yeah.
Hi, Alice. Yeah, that's nice. Excellent. Good.
Oh wow, from India.
Oh, wow.
Yeah.
Hello. Fantastic. Yeah, everyone say where you are. That's from. Morning from
Yeah.
Gibraltar. Good morning, Selena.
Yeah, I think we can probably start now, Catherine, if you're ready.
I am, yes. I hope
Wow.
that everybody can hear me well. So, good morning, everybody. I'm Catherine Backleader, and I'm the Vice Chancellor of the University of Gibraltar. And it's my absolute pleasure, on behalf of all of the university team, to welcome you to this online conference, providing an international perspective of healthcare education in practice. As a university and a young university, research and scholarly activity are an essential component of our mission and also our vision. Indeed, our vision is to be an institution of excellence in learning, teaching, and research. And as such, we value the creation, transmission, and of course, the application of the knowledge and insight that is gained through academic research. We also have a very strong commitment to research that is recognised for its international significance and its impact. And indeed, over the last 5 to 6 years or so, we've established a Centre of Excellence in Research Gaming, as well as research hubs in environment, natural sciences, business and management, history and culture, education, and, of course, in health. We've increased our international standing in research such that we've been invited to collaborate on research projects with some of the top international universities across the globe, and that includes Cambridge and Yale. And importantly, 85% of our publications have been published in high impact journals. And as a young university, we're very, very proud of these achievements. And I might add, I suspect that many universities of a far greater age would be equally proud of such achievements. Therefore, we are delighted that this conference will provide an opportunity for researchers to share their research from a global perspective in relation to healthcare education in practice. Before closing, I would like to thank Dr. Louise Lawson, our Senior Lecturer of the School of Health Sciences, Dr. Leon Lentz, our Senior Research Associate and Research Programme Coordinator, and Dr. James Vinalis, our Head of Health Sciences School, for all of their hard work to organise what I am sure is going to be an insightful, evidence-based conference. So without further ado, please allow me to invite Leon as chair to commence the conference, and I'm sure he's going to cover a little bit of housekeeping detail as well. And I look forward to hearing some of what I'm sure will be great feedback on this conference. Thank you.
Thank you very much, Catherine. As Catherine mentioned, my name is Leon Lians, and I will be serving as your chair today. Before introducing our first speaker, I would like to cover a few essential housekeeping details to ensure a smooth experience for everyone. To keep our sessions clear and free from distractions, all attendees will be muted throughout, and their cameras will be switched off during the conference. This helps us maintain a seamless flow that ensures that everyone can focus on the presentations without interruptions. We encourage you to use the chat function to share your thoughts and messages, share where you're from. Your contributions, of course, should be relevant and respectful, as this will help create a positive and productive environment for all. If you have any questions for our speakers, please submit them via the Q&A chat feature during the designated Q&A periods. Our chair, myself, will read out these questions to the speakers. This is your opportunity for us to delve deeper into the topic that interests you most. You can raise your hand following a speaker's presentation. Depending on the time available and the order of hands raised, the chair, myself, may unmute you to ask your question directly. We will be recording the conference, therefore, if anyone would not like to appear in the recording, we would recommend that you limit your questions within the Q&A chat. You can raise any questions that are not addressed during the conference will be compiled from the chat and shared with our speakers following up after the event. Please use the chat function to reach out for support if you have any technical issues, and our team will do our best to assist you. We will be announcing the breaks throughout the conference, so you'll know exactly when it's time to step away and when to return. Thank you all for your attention to these details, and we are very excited to get started. It is therefore my very great pleasure to introduce our first speaker, Professor Guillaume Alinier, who is a professor of simulation at Hamad Medical Corporation in Qatar. Guillaume began his academic career at the University of Hertfordshire in 2000, developing and leading a large multi-professional clinical simulation center. This became a hub which facilitated collaboration among students, clinicians, researchers, and engineers globally. Since 2001, he has been involved with major healthcare simulation societies in the UK, Europe, and USA, serving as conference chair and co-chair. His work spans various clinical specialties and simulation modalities. He initiated significant ECMO simulation projects in Qatar, organized major incidents and mass casualty exercises. Currently, he is the Director of Research at Hamad Medical Corporation Ambulance Service in Qatar and a visiting professor at the University of Hertfordshire, Northumbria University, and Weill Cornell Medical Qatar. The title of his talk is Challenging Learners Using Immersive Scenario-Based Simulation in Healthcare Education. And without further ado, I will hand over the mic to you, Guillaume.
He's still on mute, Guillaume. We can't hear Guillaume.
Okay, so I couldn't find the unmute button. Thank you very much, Leon, for the introduction. Thank you very much, Luis, for inviting me to this Congress. It's a real pleasure to be with you today, and really an honor. So I will try to stick to time, but don't hesitate. And I also would like to, have interaction with the audience, but I will not be able to see a chat box. So I will rely on our conference chair to kindly relay questions or your comments. So this is me, and I will talk about challenging learners using immersive scenario-based simulation for practice in healthcare education. Few conflicts of interest or disclosures. It's been mentioned in the introduction. I've got affiliation with several simulation societies. It's all kind of voluntary affiliations with journal editorial boards, and I also have a couple of books, one for which I receive royalties, the one that is published in French. So, in relation to the title of my talk, there's one word I've not used for a purpose because I will mention that's the word I would like to unpick with you. So challenging in the sense that it's common for learners to be pushed to their limits during simulation-based activities, especially scenario-based simulation activities. And often we use some form of deception, and that's the word I really would like to explore with you and get you to reflect about. So first interaction with the audience. who believes deception is commonly used when facilitating scenario-based simulation? And we will look later at how to define deception. But right now, who believes deception is commonly used in when we run simulations? So I'm not talking about skills training. I'm really talking about simulations where we exposed learners to realistic simulated patient encounters. So who believes deception is commonly used? So Leon, if you have any responses so far?
Someone has responded not intentionally.
Okay, interesting. We'll see.
And another person, I've never made that connection before.
Okay, so it's quite controversial, and I will then look at an article published now a couple of years ago on that very topic.
Another person has written, depends on how you define deception.
Exactly, yeah. Who thinks it is okay to use deception during simulation? And again, deception I've put between quotation marks. We will unpick, how to define it and what is defined as deception. Is it okay to use deception?
Everyone can feel free to write into the chat. If it is implemented in a psychologically safe manner, someone has written.
Yeah, interesting, yeah. So going back to education in general, so education is a vast topic, can take all shapes and forms, based on the learning objectives, based on the complexity of the task or concepts we want to impart to our learners, the time available, the resources available, the level of the learners, and also the individual learning styles preferences. Some people don't really like to be put on the spot during an activity, and they may feel overexposed during simulation, especially if you've got AV systems and observers in another room. Some people can be very conscious. And that's the psychological safety aspect that one of the attendees mentioned. So visual, kinesthetic, auditory learners all have different learning style preferences, but simulation is about recreating an experience for learners so that can prepare them for real practice. So eventually they will be observed while treating patients. They might be observed by relatives. They might be judged also by the patient themselves. So they need to become used to that. So I've put some pictures of Lego because I think it's highly relevant to simulation. And you got the kids here, which are your learners, and all the Legos are, the equipment in your in your simulation facility, the clinical environment, or, a dedicated simulation facility. You put it all together, the learners, the students, will do an activity with that. So depending on you as a facilitator, whether you've kind of planned an activity with, a scenario that you put the learners into, or you let the students just play in practice different things, depends how the Legos are used. Here, the kids are using their imagination to create a theme, and they will, imagine a story. They will start to build the scene, the environment, and then they will play with it. So in sim, we've got some control as facilitators about how we create the environment, what type of scenario we want to engage the learners into. So it's very much like the Lego. We've got some control within limits because they can then start, they've got their truck, their characters built, then they decide where, how, when they move them. And it's pretty much the same in scenario-based simulation. As soon as the scenario starts, and if it's highly immersive and totally learner-centered, the learners become in charge. So they decide what therapy they provide, depending on the condition of the patient. The only control of the instructors are more or less, the deterioration, the response of the patient, and a few other aspects where, in fact, deceptions might come into play. So we take the role of facilitators of learning, and we've learned to develop strategies and tricks of the trade, in fact, to still obtain, what we want from the educational activity, to make sure that the, learning objectives are addressed, and see whether, the students have mastered, what is being looked at. I've put the other pictures with the, the tin can telephone, because at times we need to give some instructions or give some pointers to learners. Here in that picture, if the kids are not, pulling the string, the sound will not travel, correctly, and the tin can telephone will not work. So at times, we need to, give some prompts to learners when necessary, because it's an issue of the simulation technology. If you give them a proper phone, they would know how to use it correctly. If you give them a real patient, if you give them a mannequin that does not exactly function like a human being, they may, if they want to feel the pulse, they may have to do it a slightly different way on the mannequin, because it's not always, exactly like on a real human being. So we are there to, help create the magic of simulation, and we need to be trained to do that correctly. And in terms of training, the practice of simulation is guided by an increasingly informed community of educators that are, guided by a lot of documents now that are emerging in terms of practice guidelines, accreditation standards, and simulation societies. So I've put a few here, like CSAM, Society in Europe for Simulation Applied to Medicine. Journals, there are many specialist journals now that have been created. You've got books, you've got other societies which have accreditation and certification program for educators or for the simulation facilities, and you've got standards of best practice for simulation in general, and for also the simulated patients. So in Axel, I've been involved with writing a couple of the standards over the years, and we're now at the 4th edition of some of the standards. These are the various standards which are published open access in the journal Clinical Simulation Nursing. INAXOL is the International Nursing Association for Clinical Simulation Learning. I've put some links, in fact, to most of the articles with QR codes. In the last edition, 2021, 2 new standards have been published, highly relevant to what we've discussed so far in terms of developing educators, which are professional development. And then the other one, which is key, in fact, to the concepts of deception, is pre-briefing, preparation, and briefing. So making sure that the learners know what they're going to engage into during the activity. Doesn't mean to tell them what the activity, what the scenario entails, but is to set expectations as to how they should behave during the simulation, also during the debriefing that follows the activity. So what's the link with deception? And why again are we talking about deception in an educational context? So what is deception? So some definitions here that I will put up. So it's a deliberate attempt to lead others to belief, any attempt to hide or misrepresent the truth, any attempt to deceive someone, making a false statement, and not giving information someone would want. So these are aspects of deception. And all of these, in fact, are commonly used in simulation for good reasons. We know, let's say, looking at the last one, not giving information someone would want. from the start of the scenario, as the facilitator, you know what will happen into the scenario within a few minutes. And yet you're withholding that information from the learners because you want them to, think on their feet and react to the situation at the time. You don't want to give them extra time to think about what will happen. You want that to unfold as a surprise to them. So, that's an example of a form of deception. So it carries a negative connotation, but if it's for the good of the learners, for the good of the learning experience, I think it can be justified. So do you recognize any that apply in your activities when you facilitate simulation-based activity? I hope so, and I think I will try and convince you even more. So despite all the technological advances we have in terms of the simulation technology, the mannequins, and irrespective of the modality that we use, deception still remain an important element of simulation that is required for learning to occur, and that's done with good intent. At times it's because what we use is not optimally designed for from an educational perspective. So it's not done in a malicious way, it's done for an educational purpose. So what is deception? It's also allowing learners to believe something works one way when it actually is achieved differently. And I'll give you some examples. And in fact, most of the time, learners do not need to know how things work. Like here in that picture, you can see the little girls are pulling properly on the string. At that age, do they need to understand, that it's vibration of sound waves traveling through, the string with under tension, or not? It depends whether you want to teach them some principles of mechanics or physics. In the case of your patient simulator, have you ever wondered, how does the mannequin, a piece of rubber, produces a pulse oximetry wave on your patient monitor? In fact, who knows how it works on the mannequin? So my background is actually physics, so I'm interested in all the electronics aspects. So what it does, it's just a sensor. So you got the LED on one side of the probe. On the other side of the probe, you've got a receptor. And as soon as you obstruct the beam, it will tell the computer of the mannequin that it's supposedly the pulse oximeter is on the finger of the patient. Whereas in fact, you can put a piece of plastic or anything else, a clipboard. You can attach that pulse oximeter onto a clipboard, and it will automatically display the SpO2, at whatever value you've set on your computer. So we're just deceiving learners to make them believe it's a real pulse oximeter giving a real reading, when in fact it's not. But it doesn't matter. Learners do not need to know how it works. Deception can also be about, can have more concerning effects with regard to learners. Making a scenario too easy, too difficult, unrealistic, can create a false sense of overconfidence and security to learners, and is not actually preparing them properly for the real world. So whereas, if you give them all the information from the beginning, they'll think they'll be ready to take on anything when they're not. Another aspect would be allowing for negative learning to take place. So you allow learners to, reinforce bad practices, and you don't pick it up at the end during the debriefing. So that is also, could be considered a form of deception. Revealing in advance to experienced learners what will happen during the scenario. Again, you're kind of preventing the opportunity to check their decision-making, their clinical decision-making process, and so on. Always making the patient survive or die, can be hard psychologically for the learners if they constantly, have the patient, passing away under their care. Also can give them a false sense of overconfidence that they can they can, resuscitate all patients. They can prevent all death. So that's something to consider. But again, that's something to discuss as part of the pre-briefing with your learners. So why learners may feel deceived? It could be because of the misunderstanding of the simulation model. So the pre-briefing did not clarify expectations of the potential element of surprise in the activity that is embedded to make it more realistic. It could be the discovery of an unexpected content aspect during the scenario. So they may at some point feel tricked by an action of an embedded participants or the unrealistic deterioration of the patient. It could be about the absence of immediate consent from the learners, and another aspect that could be hard would be the case of unannounced simulated patients. I don't know if you've heard that, but in some places they use unannounced SPs, especially for GPs, for example, to evaluate practitioners when they're having consultations with patients, and it's only after the activity that they're told, oh, by the way, this second or third patient you saw during the day was actually an evaluator from another practice, and this is we'd like to discuss how you manage the case. So this is unannounced, but usually there would have been pre-warning at weeks in advance or something that would be a practice they would be exposed to. But it's a form of deception as well. So back to you. I'd like to get your response on that. Do you see some benefits now in using some form of deception during simulation-based activity? And do you see where the deception fits? So allow you a couple of seconds to respond.
So people can respond in the chat, yeah?
Someone's responded, I sometimes leave out something that the learner needs so they learn about gathering the information.
Yeah. Yeah, don't provide the information too easily. Get them to ask. So what I would do now is explore a couple of articles around simulation fidelity, and that's where deception element is quite useful. So first article published, I think 2015, with colleagues from London, including Imperial College. That is about redefining simulation fidelity for healthcare education. And there are many models that have been published, defined to look at to explain fidelity, and there are many dimensions. And we'll try to look at some of them. But simulation is not only used in healthcare, of course. Many other professions that are exposed to sims, including pilots, maritime captain, lawyers. I remember at the University of Hertfordshire, we've got a law court for simulation practice, and even hotel receptionists take part in simulation, and they have competitions. My wife has been invited a few times as a judge to such competitions, and they are exposed to sims. So here we've got two pictures of oh, why has it disappeared? Sorry. We've got two pictures of scenes of a receptionist dealing with customers. So they might be exposed to the same scenario. Which experience, according to you, looks more realistic? Is it the one on the left or the one on the right? And I think quite rightfully you will say that it's the one on the left. You've got the reception desk. You've got receptionists with a badge. So you can make out what they are doing. They're probably giving directions. New to a city, they've got a map, and they're asking information to the receptionist. In the other picture, the scene is taking place in like a lecture room. So there is no context, no environment. So the level of fidelity is lower. So it's not as realistic.
Yeah, we've had 2 responses saying left as well.
Yeah. So we've looked at dimension in terms of the facility, so the desk of the receptionist. So in that model that we published in 2015, we had 3 dimensions. We had the patient dimension, we had the facility, and we had the scenario. And that was that triangle. And around it, we have a double circle. So any line, the higher you go to the outside of that triangle, the higher level of fidelity in that dimension. But at times, to achieve the full reality, you need to go the extra mile by some form of deception. And that's the X reality gap that we defined. So let's look at some examples here of application of that model from 2015. So first one on example A in that article is the practice of basic venipuncture with a kind of low fidelity part task trainer. So the patient dimension is near the center. You're in a clinical skills room, so it's kind of very mid fidelity in terms of the environment, and no scenario. So there's no proper context as to why they are practicing that skill. They're not interacting with the patient. They're not communicating. So that's quite low. So you can see a very small shaded area in terms of fidelity for that scenario. The second one would be the same skill being practiced, venipuncture, but you're using hybrid modality. So which is you've got an actor wearing a strap-on venipuncture pad, so the learners can start to communicate, and they are using the equipment and so on. And you're in a simulation facility, and they've got a scenario, so you've got a lot more shaded area. The last one, you'll do the same maybe inside you, so in the actual clinical setting, so you get an even bigger shaded area for the environment. And I'm aware of time, and I need to start moving on a bit. So this is just what I explained. So, but we thought that that model was not complete because it was missing the level of engagement explicitly with the patient. So I started to ponder how to capture an additional dimension, and moving from 3D to 4D was a lot more complex. And started to draw this. It was too difficult to explain in an article, and I gave up, and I teamed up with my colleague Donny Oyo to look at that new model of fidelity, and that was kind of a contentious article. It was quite difficult to publish, and attracted quite a lot of interest quite rapidly. So there was a podcast by Victoria Brazil and Ben Simon from Australia quite quickly on it. And then lots of journal clubs invited us to discuss and unpick our article. So it was published in 2022, I think. So there are positive aspects of deception. And they are applied, using tricks of the trade. But the learners most of the time do not need to be made aware of it unless it's to prevent negative learning. So, for example, I've done a lot of work on ECMO, and to recreate emergencies, such as bubbles appearing in the circuit and so on, we need to modify the circuit. And circuit is something that the ECMO team will inspect regularly. And when we make a modification to the circuit, we don't want the learners to learn to accept such modification to the circuit. So that's something that you need to reveal to the learners. If you see a T-junction here, it's not normal, but it's for the simulation. So these are some forms of declaration you need to make, but we don't tell them why it's been added. And that's where the deception lies. Maybe it's to create a leak, maybe it's to manipulate the pressure in the circuit, to introduce bubbles, to change the color of the fluid, and so on. So another aspect is on transparency versus withholding information. So with regards to revealing the contents of a scenario versus surprising learners or enforcing them to exercise their critical thinking and decision-making as a scenario unfolds. Then the other aspect is not engaging learners in the activity, and hence the lack of realism, how they interact with during the scenario. This could lead to ineffective educational activity, despite potentially reaching the educational objectives, even if the same resources are used, but depending on the facilitation approach that will dictate how the learners engage. So pre-briefing, I've mentioned earlier on, helps really to make sure that the scenario and the activity will happen properly. And that's, really been addressed with some of the inaugural healthcare standards of best practice. And a lot of articles now have been published about the importance of that pre-simulation phase. Don't jump directly to the simulation. The learners need to know what they are going to be engaged into. Even if they've been engaged in simulation activities before, it doesn't mean that your way of doing simulation is the same as your colleagues' way. So that orientation and briefing phase is important to make sure that they have a valuable, and beneficial learning experience. So it could be introduction to the mannequin, to the environment, explain things that work for real, things that have been modified, and how it differs from real clinical equipment. Also helps to say the fiction contract. So again, things that we want them to accept, to accept the limitations of the simulation. So suspending disbelief. Setting up ground rules, mutual respect, professional conduct, confidentiality, and how the debriefing process will take place. And then you've got the briefing immediately before the scenario, the starting point. What do you tell them? You tell them this is the morning, you're the start of your shift, or this is now handover. You're going to be met by, the incoming team or the outgoing team, your colleague. And all that aspect, will play an important role in the kind of phenomenological dimension of the fidelity, which is the new dimension that we've added to that model. So we've got the environment, we've got the patient, you've got the semantic, which is the scenario script, what happened during the simulation, and the phenomenological, which is how the students engage in the activity. So briefly, let's look at the ethics of deceiving learners in education. So it is underpinned by a fiction contract. It's about beneficence for the learners, it's for their benefit, and it's followed by good judgment debriefing and tailored to the level of the learners. So again, you need to make sure the activity and level of difficulty is rightfully tailored. So the model, instead of using triangles, is now using these rectangles. One aspect is the level of fidelity realism. The other aspect is the amount of deception in these dimensions, which I've briefly described: environmental, patient, semantical, and phenomenal. So if we look at some quick examples, we've got a scenario in an ICU, in situ, so in the real setting, and we've got the patient on a monitor. All the monitoring is in fact not coming from mannequin, but coming from the computer. And yet, all the cables, monitoring cables, are connected to the mannequin. The students don't need to know how that is made to work. So that's the aspect of deception. They don't need to be told. They're just made to be led to believe that it comes from the mannequin. In terms of the patient, it's a mannequin. And again, a lot of things into that mannequin are not real. It's connected to an ECMO circuit. And again, that ECMO circuit is as a system to make the blood color change. So we're using thermochromic ink, heating and cooling to change the color of the blood, so to simulate the oxygenation. To the clinician, it looks like it's real blood. It looks like there is a real oxygenation process that takes place. And it's a high level of deception because in fact, it's based on the color. And again, they don't need to know that, but that's again, a form of deception. But you're not there to teach them about the chemistry or physics of the thermochromic ink. From a semantic point of view, in fact, it's a demonstration. So we are simulating a decannulation, and then the instructor is telling them gradually there is a slow deterioration of the patient, and is telling them how to manage that decannulation, accidental decannulation. From an engagement point of view of the learners, phenomenal aspect, it's all guided. So it's not really immersive. They are not independently thinking about what they have to do. They are directed. So that's a low level of fidelity. Another quick example here, we've got an example, let's say, of a road traffic accident. It's happening outdoor with paramedics. It's meant to be on a highway, but for safety purposes, we're doing it in a car park. So it's not totally realistic. And we're using a simulated patient, and in terms of the environment, equipment, we're using a stethoscope that has pre-recorded sounds. So it's not the real sounds that will be listened to on the simulated patient. The patient is an actor, highly realistic with moulage, for the wounds. But again, auscultation is, there's a trick of the trade with a fake stethoscope. Semantic, the scenario is realistic, except the location will allow the patient to deteriorate or evolve normally. And high engagement from the learners. There is no intervention from the facilitators. So it's highly realistic in terms of perception, or in terms of engagement of the learners. So now, who believes, having seen all these aspects of deception, do you see now how deception is commonly used in sim? So it could be, aspects of the technology. And in fact, even yourself as facilitators, you are deceived, let's say, to think that the SP, the pulse ox, is working like a real pulse ox when it's not, but you don't need to know. So who believes deception is commonly used in sim? Any responses?
Please feel free to write in the chat if you have any responses to the question. We've not had any responses as yet.
No? Okay. So again, another piece of work that we've done is a meta-analysis of use of deception in simulation-based education. We reviewed 12 articles that were related. And in general, the feedback from the learners or, the study participants was that deception, is accepted by learners and facilitators, when it's used for good intent. There was a couple of studies from the same team that looks at deception where, they were forcing participants to challenge the authority of more senior embedded participants. So, that were making the wrong decision and they were expecting learners to challenge them. So that was the aspect of deception, which was the scripted action of these embedded clinicians into the activity. So in conclusion, simulation is a multi-dimensional activity with elements motivated from a realism point of view. Pre-briefing and briefing are really important to make sure that the activity runs smoothly. Deception is really present in simulation to varying degrees. It's generally accepted by learners, but just that we never use the word deception in the activity because that's not well perceived. And learners' reaction, really need to be further explored, further research in relation to deception. These are some of the references I've used in this talk. This is a view of West Bay, where I am normally when I'm not on holiday in France, like right now. And thank you.
Thank you very much, Guillaume, for your fascinating talk. Unfortunately, we don't have any time for questions at this point. However, please do feel free to send your questions to the Q&A, and I will ensure that Guillaume gets the questions and is able to respond after the conference. Therefore, what we'll be doing now is introducing our next speaker, who is Dr. Louise Lawson, who is a senior lecturer in the School of Health Sciences at the University of Gibraltar. She is an expert pediatric, neonatal, and adult registered clinician and senior educationalist with over 35 years of experience in both nursing and higher education. Louise has worked as a nurse in the UK, Saudi Arabia, and the UAE before moving into higher education, specializing in both undergraduate and postgraduate nurse education. Louise has also taught nursing for 10 years in Malaysia and the Penang to nurses, topping up the diploma qualifications degree level. Academic qualifications include a doctorate in education, MA higher education, BSc Hons adult nursing, and a teaching fellow of the Higher Education Academy. Louise has extensive publication and international conference profile relating to mentorship and learning in nursing. Therefore, I am pleased to introduce the title of her talk, The Art of Heuristic Learning in Gibraltar, Student Nurses' Perspectives of Discovery Learning on Placement. So without further ado, I will hand over the mic to Louise.
Can you hear me? Can
Yes.
everyone? Yes, good. Okay. Now I've lost my screen there, but can you see this? Can you still see my screen?
Yes, we can see your slides.
Okay, that's fine. Okay, so I'm going to present to you today my research that I carried out recently in Gibraltar. And one of the reasons that I wanted to carry out this research really was so that I could look at the way that students learn, because one of the themes that came about in my PhD was about the way that people learn. And obviously, we all know that students learn in practice with their mentors and with other people. But what I really wanted to find out was about their learning, how they learn independently. So obviously, for student nurses, their program is 4,600 hours and 50% of that time is in practice. So so they're doing 2,300 hours of learning in practice. And so it's really important that we get this right. So I looked at the literature around learning in practice. Now, obviously, there is quite a lot of literature about nurses learning in practice. However, what there seemed to be a lack of literature was any literature or research relating to learning in Gibraltar. So that was really essentially why I wanted to put Gibraltar on the map and to increase our research profile in Gibraltar. So really what I wanted to find out was, how do student nurses learn independently on placement in Gibraltar? So the way I went about that was a qualitative descriptive design, generally following the Husserlian phenomenology. I had 10 second-year students volunteered and 5 third-year students volunteered. I purposely didn't recruit any first-year student nurses because the students had only done a short formative placement when I was collecting the data. So I only had second year and third year student nurses. The aim was not to compare the student nurses' experience. However, I have realised that this is perhaps room for another study in the future about how the differences between year 2 and year 3 and how they learn. So I carried out 15 semi-structured interviews over a course of 2 months, and I analysed, well, the audio recorded, and I analysed the data using the Lawson 2022 thematic analysis framework, which is something that I developed through doing my PhD. So from that, 3 themes emerged. So the first thing, I'm going to go through each of these themes individually. So the 3 themes that emerged were active learning through real life practice, the role of guided discovery learning in practice, and cultivating independent thinking. So the first one, active learning through real life practice. So this sub-theme, the synergy between passive and participatory learning, what the students talked about was the value of being a passive learner. They really valued that. Actually, you know, they knew that they were being passive. So for example, they gave examples like in a CPR situation where they didn't really know what to do, so they felt that they were passive learners. However, what they felt that through that observationary type role, that they really learnt a lot just by standing by. You know, but they also compared that to participatory learning, where they started to get their hands, you know, dirty as such in a CPR situation, so that what they felt was that they learnt from standing back and doing nothing, but they also learned from, you know, actually getting involved in that particular situation. What they were saying was that active learning of being involved, but also that they definitely learned by being passive as well. So the collaborative versus self-directed was really about, you know, active learning with their peers, that they wanted to learn through other healthcare professionals, that they actually went out of their way to find other healthcare professionals who they could learn from, so that and with the self-directed learning, what they meant by that was that they would go off and speak to patients, or that they would find, you know, any learning opportunity, something like if they knew that somebody was going to have a dressing, or the physiotherapist was coming to do percussion or something on a patient. So those learning opportunities, but being collaborative, working with others, was just as important, and they valued the self-directed, where they were able to go out and discover their own learning for themselves. They also talked about reflection and debriefing with their peers. So it wasn't just about reflection. They said that their mentors encouraged them to reflect on their practice and debrief at the end of the day. But what they felt that they learned more was reflecting with their peers, often in the coffee room or after work, or with their friends, you know, in sort of just in a social situation, was that they actually learned a lot through this reflection, and that they've been encouraged through reflective practice to learn from their reflections in and on action. So the formal reflection, yes, they learned from, but they felt that they learned more from the informal reflection and debriefing that they had at the end of the day with their peers and not just their mentors. And then the development of inquiry-based learning attitude was that the students were encouraged by mentors and others to have an inquiry mind. And when I say others, it wasn't just, you know, mentors. They were encouraged by even healthcare assistants and patients as well, that they were encouraged to go and find out about, you know, the theory of a particular condition, rather than just, you know, getting on and doing it, getting, you know, hands-on. They were encouraged, and this is what they felt, that's how learning took place for them, was the fact that they were encouraged to be inquiring and inquisitive about what they were doing and why they were doing it. So this independent learning, they felt, was really, you know, valuable to them. So the second theme was the role of guided discovery in discovery learning in practice. So the students admitted to, they spoke of learning through trial and error. So the students gave examples of some of the things that they did that they didn't always get right. Sometimes they had to guess what they were doing, and sometimes they had to make decisions that they felt that didn't necessarily go wrong. But this reasoning that they had with, through the trial and error and the learning that took place enabled them, especially moving from second year to third year, that they talked of the value of learning through trial and error, but also the guesswork that they felt that they needed to do, because they didn't always know the answer when they needed to make a decision. So they just went with the guesswork and just, let's hope for the best. That was one of the quotes that they said, let's just hope for the best. Well, what should I do? I don't know. So, there's been a lot of research published about trial and error and tacit learning in practice. And again, this was quite a key theme here, where learning from trial and error and guesswork was really prominent. The other thing that they talked about, all of the students, was reconstructing past experiences and existing know-how with the reality of practice. So a lot of our students have been healthcare assistants in the past, and in order to so if I said to them, how did you know how to make a decision, or how did you learn to make some of the decisions? Well, they talked about some of their experiences from being a healthcare assistant and their existing know-how. However, what they realized was that actually their past experiences as healthcare assistants didn't necessarily prepare them for the reality of practice, because when they're working as a healthcare assistant, when they now were in a situation where they were, especially the third years, was that those existing past experiences didn't necessarily help them, because obviously it was in a different capacity. But they also spoke of the value of having those past experiences and that existing knowledge, which enabled them to help to make some of the decisions that they needed to make. And they also use this rule of thumb, this balancing, this rule of thumb reasoning with evidence-based practice. So the students talked about using their common sense and, how this is how other people do it. So we'll just go with the rule of thumb. However, they also noted that they knew that this was not necessarily some of the practice that they needed to look at the evidence-based practice, and that the rule of thumb didn't always apply. So that they looked at the latest evidence, they went away and looked at some of the conditions. Are we doing it? Are we up to date? Some of the students said that they went onto the NICE guidelines and looked at the current practice, looked at current research, which is what we as lecturers have been encouraging them to do, but also that they knew that their peers also encouraged them to look at the evidence base. So they did very much use this rule of thumb. This is how everyone does it. However, that they did realize that by looking at the evidence base meant that the rule of thumb didn't always apply, and that they needed to use the evidence for their practice. So, and then finally, the cultivating independent thinking. So this, the need for scaffolding, the students spoke of the need to have their hand held, especially the second years. They talked about when they were first year students, and that they didn't feel that they had this independent thinking, and that they were very much relied on their peers, their mentors, to tell them what to do. And actually, as they become second years and third years, that they realize that the concept of scaffolding really is about having, if you think of a scaffolding around a building, and eventually the scaffolding starts to come down. And so that they realized that actually the more senior that they became, that their mentors and their peers were telling them less what to do and encouraging them to start thinking for themselves. But they valued the actual, the scaffolding technique, even though they didn't use that word. They said that they liked the fact that they were told what to do, and they were very happy to do what they were told in this behavioristic type approach to teaching and learning in practice, and moving into a more cognitive way of thinking. They were also they felt that there was many multi-directional methods of teaching in practice, which they felt that they were able to then use on their own. So students spoke of the value of the various methods of teaching in practice. For example, like I was saying about moving away from the behaviorist approach to teaching and learning to more instructional. Sorry, that's the phone ringing. But again, valuing the learning that resulted in that direct learning, that where, you know, they were told what to do, but then starting to, when they were encouraged to think for themselves, that they realized that the importance of that. So what else is it that they realized? Again, they talked about the when they were just told what to do, that they realized that perhaps that learning was on the superficial side, so that when they were encouraged to think for themselves and problem solve and reason, that they realized that deeper learning had taken place. So there were, they used, like, for example, case discussions. So even though this wasn't necessarily with their mentors, this is like with their peers, other student nurses, where they talked about some of the cases and they asked questions. They were encouraged to go away and find out about particular conditions, what the evidence base suggested. They also used some comparing and contrasting techniques, which again features in heuristic teaching. So they were saying that, for example, they'd have one patient in a bed who had pneumonia, and another patient in another bed who also had the same condition, but they both presented with slightly different characteristics. So the opportunity to compare and contrast same conditions but different patients, they felt a lot of value in that as well. The simulation, they talked about simulation in the simulation suite, obviously, and how that prepared them as well for some of the real life scenarios, and, you know, cultivated that independent thinking because they'd been presented with that opportunity in the past. This ability to think creatively and you know, be given that opportunity to reason with why some of the decisions that they're making, felt that they had a deeper understanding and felt that it stimulated their learning interest more rather than just being told what to do. So they did value this being given, like I say, the opportunity to think independently, and it was important, more so important in the third year students. And really this active partnership between student and others, and this really was about the patients. They talked a lot about this partnership with patients and learning from, obviously they learned from other healthcare professionals, but they talked a lot about learning from their patients and the expert patient that they talked about, and how the patients often guided them through some of the you know, procedures that they did, because the patients had been doing it for years, and often the patients would teach them about their condition in sometimes lay terms, where they were able to you know, understand a little bit more. So that was the cultivating independent thinking. So they were the three main themes. So basically, to summarize really with what I've learned from this study, was that, you know, collaborative learning on placement fosters the development of problem-solving skills through the process of inquiry and discovery learning. And obviously it was Brunner that talked about discovery learning, and that collaborative learning was not necessarily with you know, their mentors. It was with all healthcare professionals, patients, healthcare assistants, and even families as well. The student nurses used tools such as reflection and reasoning to test out ways of learning. So that was where they talked about the trial and error and just hoping for the best. They preferred the real life clinical scenarios to narrow down the options in order to make that decision, which again, they spoke about the value of those real life scenarios and how they applied the simulated experience that they had to the reality of practice. The trial and error, like I say, they spoke about the learning that they from the trial and error, and they gave plenty of examples of when they'd made mistakes and you know, what they'd learned from it. And that one of the questions was very much about, well, what did you learn from making that mistake? And the process of elimination, you know, they felt this is where the reasoning came in, and the cognitive reasoning, where they said, well, look, I didn't do it right last time, so this is what I need to do now. Students were encouraged by their mentors and others to adopt this inquiry-based learning attitude, and it was about, they talked about promoting inquisitiveness and, you know, to encourage to go and find out about things and learn from situations rather than just being, you know, standing around and doing nothing. They wanted to make sure that, you know, they were very much, what came about from this was that they were very much active learners and not necessarily passive, even though they felt that they learned from these observational passive moments. So the ability to solve problems enabled them to think independently and acquire knowledge, and they learned the art of heuristics, which is essentially about problem solving and experiential learning through this active reconstruction of their past experiences and existing know-how. So some really interesting results in this study, which some of them quite surprised me, because I sort of thought that they would be very much reliant on being told what to do and to get on with it. And actually, I was really pleasantly surprised to see that the findings from the study was that they weren't passive and they were very much active learners. So it was really good. So preparing students for contemporary practice. So moving away from this behavioral pedagogy to construct a constructivist philosophy of meaning making and discovery learning. And this is, again, what the students talked about, was about giving meaning to some of their experiences, and that came through the reflection and debriefing and talking to some of their peers. So developing, what we need to do is to develop mentors to draw on heuristic methods of teaching, getting the students to encourage them to problem solve themselves, to rather than being told what to do, which is the behaviorist way of learning, is to go to encouraging or developing our mentors to get the students to go and think for themselves. And a lot of having trained a lot of mentors in the past, myself, some of the mentors say, I feel that I know so much that I just want to tell the students everything. And you know, I've been, you know, I do that myself sometimes, because you know so much and you want your students to know everything that you know, but actually we need to sort of try and stop doing that and to try and get the students to think for themselves and go away. And this is why we do a lot of inquiry-based learning in the classroom as well. So we give them scenarios, give them trigger questions, and then they work together in a group and go away and find out all the answers, and then they present back to us in the class. So we can do that, we can apply that into the practice setting as well. And really it's about stimulating students to think independently and mobilize enthusiasm for active learning. So finally, just really give a man a fish and he'll eat for a day, and teach a man to fish and he'll eat for a lifetime. So this is really about just encouraging our students to, you know, by not being told what to do, that they'll go away and they'll find out what they need to know, and encouraging them as well to teach other students as well. So we want our students to have these skills for a lifetime, rather than just, you know, doing the job, which is what we don't want our students to do. So so really that's it. So I just wanted to acknowledge a thank you to our second and third year student nurses at our University of Gibraltar. Without them, I couldn't have done the study. And thank you to the University of Gibraltar for funding this project that I did. So any questions? I shall stop sharing, I think, so I can see the chat.
Yeah, you can feel free to write your questions in the Q&A chat. Otherwise, we do have a little bit of time for at least one
Did I go too
question
fast?
in case anybody wants to raise their hand. We have about time for about one question. If anyone wants to raise their hand and ask. The panelists are also encouraged to ask questions should they have them. Yeah. Well, actually, I've got a question. So I think it's really interesting what you were saying about the evolution of independent thinking from the second to third years. How do you think that continues to evolve as they become newly qualified? Because obviously you're always learning in this particular field. So have you thought about that?
I mean, obviously, for my doctoral study, I looked at newly qualified nurses and not necessarily about independent thinking, but how they learn in practice. And it was like they went from when the third year students felt that they were expert novices, if you know, and then when they became newly qualified nurses, they sort of became novice experts, and they felt very much the what's the word, imposter syndrome, when they became newly qualified nurses, and they felt that it was almost like going back to being a student nurse again. And so it was almost like this transition that they go from third year to qualified nurses. They felt they went back quite a lot because it was the way that they thought about being this new person, rather than because they felt confident as third year student nurses. Do you see what I mean? But then moving into that role of newly qualified nurse, they have all these anxieties. And so really, I think, like you say, there's definitely a study out there about finding out about how newly qualified nurses think independently. But I know for a fact through my research and through obviously talking to newly qualified nurses is that they do have a lot of anxieties about independent thinking, because they just want to be told what to do in the beginning as a newly qualified nurse, even though they feel that they do know what to do, but they just feel like they're going back to being a novice again.
Yeah, it's really interesting. It's sort of like going from being a senior student to a junior nurse.
Yeah,
And it's that
exactly.
psychological barrier that
Yeah,
forms.
exactly.
It's very interesting.
And there is a lot of research about liminality, which is one of the themes that came out in my PhD, this in-betweenness. The concept of liminality is about this sort of no man's land, you know, so you're, like I say, they felt confident as third year students because they were the sort of the senior students, and then suddenly they become this newly qualified nurse and they don't really know what land they're in. So that's something that I would definitely like to explore further, this concept of liminality and thinking the cognitive domain within that liminal space. So yeah.
Brilliant. Thank you so much, Louise. That was really, really interesting. So I think now we can go on and introduce our final speaker before the break. So it's not our final speaker, it's just before the break. Dr. Heather Bade, who is a registered nurse specializing in intensive care, who works as a principal lecturer at the University of Brighton. She has a keen interest in sustainability issues, including reducing the environmental footprint of healthcare and financial and social co-benefits. For her PhD, Heather explored the concept of sustainability within the context of critical care, and she is currently leading the Green ICU research project. She has facilitated sustainability to embedded into several healthcare courses and leads the organizing of the annual SHARE conference. Therefore, the title of her talk is Sustainability within Healthcare Education and Practice, and I will hand the mic over to you, Heather.
Hi, can you hear me okay?
Can hear you great, thank you.
And can you see my slides? Is it full screen now?
Yes.
Yep.
Okay, I can't see the chat at the moment, but I can see a clock beside me, so I'll keep an eye on the time. So really great to be here today. Thank you so much for the invitation. And I think there's lots of links for the previous two talks, so I'll be referring back to both these concepts of simulation and nursing students co-constructing knowledge and things together. I think that really fits well today. So my background's in intensive care nursing, but I do a lot of sustainability work. And one of the things I do is lead the School of Sport and Health Sciences special interest group on sustainability, and we host students on placements. And there are several students here today And I can't see the chat, but I'll give a call out for those students who know who I'm speaking about that are on the QAPL placement. If you want to just introduce yourself in the chat. And we're almost doing something live in action here because they're on this placement. They've joined this conference today. So this is one of their learning events where we're co-learning together about sustainability. And we'll be sharing some of our activities that we've been doing. So just to give a shout out to all of those University of Brighton students that have joined us today. The only disclosures to note for today is I'm currently leading an intensive care national project that's funded by the SPRI Healthcare and previous academic grants from professional bodies and the university on sustainable healthcare research projects. So I think most universities, if not all universities, are now addressing the Sustainable Development Goals that come from the United Nations, and there are 17 of them. And many universities, including the University of Brighton, have declared a goal to embed the Sustainable Development Goals into everything that we do. But what does that mean for healthcare? So one definition of sustainable healthcare applies this concept of sustainable development, or what's sometimes called the triple bottom line, is we need to maintain a sustainable health and care system, but in a way that's financially affordable, socially responsible, but also environmentally sustainable. And I think that environmental aspect is something that's relatively new or very new to many healthcare systems. And it's what's been the focus of much of my research, what I'll talk about today. But I just wanted to recognize the links with social. So that's about social well-being of patients and family and staff. It's about ethical procurement to make sure that supplies are manufactured in socially responsible ways, and also that it's financially affordable. Because if it's not affordable, we're not going to be able to do it. But I think what's really key for healthcare, and as educators and as students thinking about what about the quality care? Because if we're focusing on whether it's social, financial, environmental, or any of those three combinations of resourcing, ultimately we have to maintain quality care. And what a lot of sustainability projects are now doing is trying to look at it as actually, could we embed sustainability into quality improvement processes? And I'll mention a resource later on called the SUS2I framework. And thank you to the students who will be sharing web links throughout as well. So feel free to add web links in the chat as I go through. And that's really about looking at improving quality care, using quality improvement methodology, but with a sustainability lens, so that we're integrating social, financial, and environmental considerations, in addition to the clinical outcomes that we would be looking at for quality improvement. So why is planetary health and the environmental sustainability aspect relevant to healthcare education? And today's theme of the conference focusing on healthcare education and practice. Well, we all know there's a planetary health crisis. I don't know how hot it is where everybody is. In the UK, for many countries, this might not feel very hot, but in the high 20s, mid to high 20s is quite hot for UK standards. I'm about to have a big carbon footprint. I confess, I'm heading straight to Heathrow Airport after this, flying to Canada, where I'm from, to see my family, and it's all burning out in British Columbia, where I'm from. We're living in the world of constant heat waves, droughts, fires, storms, floods. And, these ongoing sustainability issues are daily on the news around air pollution and fossil fuels and plastics and microplastics in our food. We all know about these issues. These aren't new issues, but they've only relatively recently been talked about within the context of healthcare practice. And planetary issues, whether it's climate change or ozone depletion, resource scarcity, etc., often are interlinked with social justice issues, whether that be war and civil conflict, poverty, modern slavery, etc. And this combination of planetary health issues and social issues, feed into ultimately public health issues and cause more cardiovascular disease, more respiratory disease, more malnutrition, etc., which then makes people sicker. They need more healthcare. But healthcare delivery has an incredible environmental footprint itself, as well as a financial and social cost, which then feeds back into further planetary and social justice issues. So we're kind of stuck in this cycle of complexity at the moment, trying to figure out how can we both prevent and adapt to the planetary health crisis. So adaptation is about managing the risks of planetary health damage. So for example, if we're doing healthcare education, could we function as educators and students and nurses or whoever we are without electricity, without water? Well, what if those become at risk due to climate health issues? How are we going to provide that, both the healthcare education as well as the healthcare delivery? How are we going to adapt to the crisis that's happening already? It's too late to prevent it. We're already in it. So we need to learn how to safely adapt within that. But we can also have a little bit of the glasses half full rather than just glasses half empty approach and look at, well, how can we mitigate? So what actions can we take to reduce the planetary health damage that we're causing simply by providing healthcare and healthcare education? So what is the environmental impact of healthcare? It's estimated to be about 4% of global net emissions. When you break that down to different areas, it might be a bit different. In the UK, that's probably about right. In some countries, it's higher, up to 8-9% of their total global emissions for that country. That might seem relatively small, but if you think about it, that's one sector. So if it was a country, it would be the 5th largest emitter of greenhouse gases globally. So it's actually for quite a number of years now been recognized as significantly high cause of air pollution, carbon footprint, biodiversity loss, etc. And yet, I don't know how many of you as healthcare educators were ever taught this in your nursing course or medical course, physio course, whoever you are. I certainly wasn't, and nobody talked about it. And so there's been a shift towards, well, if this planetary health has a lot to do with people's health, and we are in the business of healthcare providing, well, why isn't there more of a link? So England was actually the first country to declare that it will become a net zero national health services. And that's relatively recently, only, I think it was, I'm trying to remember, it's in the middle of the pandemic. I'm going to guess 2021. So, relatively recent. The NHS England put out a net zero strategy. And they've taken it a step further, and they've embedded climate change and net zero goals within the Health and Care Act, which is statutory law. So what that means is it's a statutory requirement that all National Health Service organisations in England, Scotland and Wales now have the equivalent, and I believe Northern Ireland will be coming. And I know there's other countries that are now starting to do this as well, where it's no longer strongly recommended. We must do this because it's such a high environmental footprint. And therefore, as healthcare education and the practice opportunities we're providing students needs to be able to address this. So if you look at this pie chart, this comes from NHS England data. And what you'll notice on there is just how much of the percentage of carbon footprint comes from medicines, medical equipment, and supply chain. So that's stuff that's day-to-day resources that clinicians are using. And yet it's not traditionally been taught in healthcare education or been part of simulation experiences or been part of healthcare placements out in practice, etc. Yes, building energy is important. Yes, water is important, travel, etc. But actually, as clinicians and as healthcare educators, there's a real opportunity to address the carbon footprint simply by looking at the principles of sustainable clinical practice and how we can be more environmentally friendly and how we function within the healthcare sector. Just adding some European context, every 5 years, the World Health Organization Europe does a declaration. The last one was in Budapest. I was there a few years, last summer. Sorry, it wasn't that long ago, last summer in Budapest. And traditionally, they've looked at public health, things around climate crisis, biodiversity loss, and environmental pollution. For the first time, and this is aligned because it's World Health Organization with the COP program, if you've heard of COP, that happens every year. The first time they've aimed to make healthcare systems more climate resilient and environmentally sustainable. So there's some new work going on there from a quite high up strategic context. I looked at Gibraltar. I've never been to Gibraltar. I would have loved to have come. I guess this is environmentally friendly today and that we're all on Zoom, cutting down the travel. I couldn't find anything on healthcare sector. So if that it does exist, somebody please share it in the chat. But on my internet travels and asking a few people, I couldn't find a healthcare net zero strategy. But I did find one for Gibraltar as a whole from your Department of Environment, Sustainability, Climate Change and Heritage. And there's been some good improvements, actually, when you look at that. It's enjoyed reading some of the goals that have been reached, but obviously lots of goals to come. So if those of you who are in Gibraltar, I've put a couple of references here. I will be sharing these slides afterwards, and there's web links in all of the slides as well, if you want some of these references. So in terms of today's theme for this conference, how can healthcare education, and particularly around practice elements, improve planetary health? So Advance HE, which supports higher education in the UK, and I imagine other countries will have a similar equivalent, have long had education for sustainable development guidance. This isn't new. This has been around for a long time. I think it's the application specifically to healthcare that's been more relatively new. And the Association of Medical Education in Europe defines education for sustainable healthcare. So that's taking that broader context of sustainable development and saying, okay, well, what does that mean for sustainable education? or education for sustainable healthcare as the process of equipping current and future health professionals with the knowledge, values, confidence, and capacity to provide environmentally sustainable services through health professionals education. So the future health professionals, so, those are the nursing students with us today. Those are the, the future graduates. And so we really need to be embedding this into undergraduate education. If you're not yet doing that, I'd really encourage you. I'll provide lots of references at the end. There's also this really good document that came out for medical schools, but sustainability is such a broad concept and it should be interdisciplinary. This can't be something that the doctors do separately to the nurses, to the physios, to the dietitians, to the pharmacists. We're all in this together. And actually, most sustainability issues in healthcare really are multidisciplinary. So that's a really good resource that I think is relevant for everybody around curriculum guidance. But there's also, all the people out there working, all of us educators that are currently working. So there's also a big gap in postgraduate education. And in the intensive care education that I provide at the University of Brighton, we've been doing this for some time around embedding sustainability into what we're doing already. It doesn't need to be something extra. We're all busy. We're all say there's no room in the curriculum. It's simply providing a sustainability lens on the topics that we're teaching already. And fitting with the start of the day when lots of themes from the introduction as well as the first two keynotes is just around research. And we don't really have time to be spending years and years and years as we normally do figuring out how do we do this. The climate crisis is such an urgent planetary health crisis. We need to be doing this now. So it's looking at sort of almost researching or looking at methodologies where we're embedding things into practice as we go through in a sort of transdisciplinary and collaborative approach to be as efficient as possible. So one research example is a project that the University of Brighton was involved in a few years ago, and it built on some previous work from Plymouth University and other universities. I think there was about 5 countries involved in this one, and they evaluated nursing students' attitudes towards climate change and sustainability. And not surprisingly, pretty much nearly all of them said, of course, this is important. And in my experience, speaking to many students, they don't understand why we're asking. They just assume that it should be part of this. They, a different generation of nursing students coming in that have been taught this in their primary school, secondary school, been part of Friday marches, been part of this sort of, in the UK, there was a really popular program called, from David Attenborough, that kind of, it's called the Blue Planet Effect from that program. It's become a sort of cultural norm outside of healthcare. So why isn't it a cultural norm within our education? And one thing some students did, I think about 4 or 5 years ago now, it started with medical students in the States, it's now spread to other disciplines and other countries, is they started challenging their local university, saying, from a student point of view, why aren't you teaching this to us? We can see the links between planetary health and public health. Why isn't this part of our placements? Why isn't this part of our teaching, our simulation, etc.? And so if you've not yet found the Planet Health report card, I'd really encourage checking out the website. And it's a student-led initiative, and it runs every year. It runs on a sort of academic year, so there's time to sign up for the next year. And if you contact through the website, and it is led by students, so it's students that lead it, but they do need a lot of faculty support in order to find the information about how well their university does on certain practices. For example, their simulation rooms, their buildings, their curriculum, their research. Is planetary health either implicitly or explicitly addressed, and if so, how? And then there's a rating system, and whether you get an A, a B, a C, a D, etc. And we've done the nursing pilot a few years ago, and one thing that we give our nursing students who are on sustainability placement, for example, some of the students here today, is the time, protected time to complete the report card, because it does take a bit of time. And then there's a report which is released on Earth Day. So it's a really fantastic example of what the previous talk was saying around, co-constructing knowledge with students, active learning, inquiry-based learning. It's a really good initiative with lots of international collaboration that comes about because the students then collaborate with other universities as they register their projects. I'd highly recommend it. And Emma is here today. Emma's in the photo. She's a current third-year nursing student at the University of Brighton, and Christian was a third-year student last year, and he's now graduated as a mental health nurse. And this is an example of one of their activities they did on a sustainability placement. Because we were teaching sustainability for actually many, many years at the University of Brighton, and we're really good at doing it in the theory classroom. And this bottom left corner was an example of a sharp spin that I noticed in the simulation room one day, and I thought, oh goodness, we're teaching how to be environmentally friendly in healthcare, but we're not practicing what we preach in the simulation rooms. And so we sort of collaborating with other universities. ASPE was mentioned by the first speaker today. They've developed a sustainability special interest group and, developing some guidance on, well, there's guidance for sustainable healthcare out there. Well, why can't we do that? Well, there's simulation activities happening in our own environments. And we've addressed certain things like sharp spins, gloves, aprons, which tended to be overused. And it's just setting bad practice. And in fact, gloves is one of the hot topics at the moment in the sustainable healthcare world, because there's lots of research for a long time that say clinicians typically overuse gloves and don't do hand hygiene frequently enough, and infection rates goes up. So it's bad for patients the way we currently use gloves. It's financially expensive and it's got a huge carbon footprint. So I think some of the students are going to be sharing some gloves resources, and one of their other activities the current students are doing at the moment is they're going to go out to one of the local hospitals and they're setting up a table in the sort of foyer area where they'll get lots of foot traffic of staff and the public, and they're just going to be sharing this kind of information. They've created a flyer. So I don't know if they'll be able to share the flyer in the chat. One of them wants to do that, and using Royal College of Nursing and Intensive Care Society glove resources that are already out there. And I would say there's a huge amount of resources that are being developed. We don't need to reinvent the wheel. And if you're at the very beginning of this, I really encourage you just to look at what's there already. And this, just examples of activities that the students are leading on and doing in their practices. They've done waste audits. We've also had waste audits done by MSc environmental students from a different school. We've had sustainable design students collaborate with us in the simulation rooms, practicing their prototypes. So some of the things around fidelity and, the concepts that the first keynote speaker was talking about around, safety and things that, simulation has advantages and disadvantages as he reflected on it and explored, but it provides a living lab, is a common phrase used for simulation, isn't it? For not just our own disciplines, but other disciplines to improve on more sustainable practices. So we do provide a sustainability placement for students, and I've already mentioned the Plant Health Report Card. We host a conference every year. We haven't set next year's date yet. It'll be online, probably about May, June time. I think one of the students is going to share the recordings from last year. And so every year, these recordings, like you're doing today, you record all these conference sessions. You've got instant e-learning materials for other learners or educators to use. The SUSQI framework is a framework I mentioned earlier, using quality improvement methodology with a sustainability lens. Comes from the Centre for Sustainable Healthcare, which is an organization based in Oxford. They make all of their resources openly available. So if you go to the susqi.org website, you'll find all of the tools around how you go about a SUSQI project. And we're encouraging students now to use SUSQI methodology, because there's a lot of quality improvement or case studies or other projects that might not be explicitly quality improvement, but they're implied, or just how we're improving quality as educators. And so if we use that SUSQI framework, then we can be attending to these sustainability concepts at the same time. And I think hot topics at the moment, as I mentioned already, are sharp spins, waste segregation, gloves, aprons, and reusable as much as possible. So I was really interested in that first talk, discussing around deception. And actually, in the postgraduate OSCEs, the clinical exams that we do, we don't ask our students to wear gloves. They're not being examined on wearing gloves. We know they wear gloves as they need to in real life or wash their hands. We're doing a simulation scenario about other concepts. So if they say that they're wearing gloves and, they're going through a deception of it, but that's an acceptable deception, then that's absolutely fine. I think what's needed is clarity on what's the learning outcome or what is the specific goal for that particular activity, and looking at the resources that you use within it. For example, a first-year nursing student learning how to put on sterile gloves, well, then that's part of the learning experience, so they need to wear them. A postgraduate student that is there doing something else that just says that they would use equipment in a different way. Or another thing we're doing is we're repackaging Foley catheters or, different clinical supplies. They're not technically sterile. They look like they're sterile. The student feels like they're sterile. Whether they're actually sterile or not doesn't make any difference to the plastic dummy. So there's lots of opportunities like that within a simulation environment to be improving on reducing waste. So just in summary, what have we learned? We have a special interest group. And I think when I first started, I felt like I was the only person that cared about these things. And then you find out there's actually lots more people out there. And I think, all about teamwork and collaboration. So working with people locally within your institution, but also finding your like-minded people elsewhere. For me, it's intensive care. So, finding this special interest group or sustainability people in the community. in the simulation world, that, as I said, ASPE now has a sustainability special interest group as well. We've got really proactive collaboration arrangements, which are already there for placements, and if the healthcare services are working on sustainability, then why not, work together on this with students? We've had really highly motivated students and staff buy-in, which I think helps. There is a school commitment you can do. So if you go to the Healthcare Without Harm Europe's Nursing Climate Challenge, they have an individual challenge declaration, but you can also sign up as a school. It does say a nursing school pledge, but we're not only nursing. We've got podiatry, physio, paramedics, radiography, etc., lots of other disciplines, and that's fine. You can still sign up to it. And what that means is you get your dean support. It goes on the website. It's outward facing. It's saying, hey, as a school, we really value this, and we're trying to do something about it. And then you get resources and networking through that Healthcare Without Harm Europe organization. I think having university strategic support, we've had fantastic support from our Vice Chancellor and executive. But if you've only got the top down, you also need lots of champions and teamwork and collaboration. And embedding this into local research. We've got PhD students working on these types of topics, MSc students, quality improvement within lots of BSc level students as well. Clearly lots of challenges, planetary health, goodness, where do you start, right? It feels so overwhelming, but sort of making small tasks that are manageable. But that can be, overwhelming. We're all busy. We're all a bit post-pandemic, and as I said, the way we look at it isn't something to just add in as a tokenistic extra. This is something that we can just embed into every single thing that we do. We need more evaluation. We need protected time for technicians and academic staff to be able to at least find some initial time to do that sustainability lens. And there's really minimal research in this area. But watch this space for ongoing projects. And if anybody's interested in this type of topic, please do be in touch, because this is all about collaboration, and there is a lot of different sustainable healthcare research work starting to sprout up. I am to time, and I wasn't planning on using these slides within my talk. I'm just going to whiz through them and just show you, when I share the slides in the chat, all the different resources that are out there, all the different models and circular economy resources. I've mentioned this sustainable healthcare. There's lots of different networks. There's one on sustainable healthcare education as well. So if you had questions around practice as the theme today, you could post it on their blog site and use that network. Mentioned this resource already. As I said, there's just lots of different things. This whole resource coming out of it's an international collaboration, actually. They're using problem-based learning approach with slide decks and learning objectives. The medical resources have been there for about a year, and the nursing ones are going to be launched by the end of this year. Some of our nursing students have been creating case studies for this. So if you're looking for an activity for your students, you could put them in touch, or I could pass on the links, and that's something that students can develop case studies for, and then it goes into this repository of free resources for healthcare educators around climate resources. Life cycle assessments is carbon footprinting, so there's a growing number of research studies in that area, and there's a database, freely available database on that now. As I said, we've got a special interest group. You're very welcome to peruse through our website. Emma, who's here today, she did a video on using simulation on gloves use, and Christian, the mental health nurse from last year, did one on eco-anxiety from a mental health point of view. So those simulation videos are on there, as well as a variety of other resources. Please do come to our Share conference. We'll let you know when it is, once we've set a date. And just a final thought, if we're greening up and we're doing things financially sustainable, environmentally sustainable, I mentioned it briefly at the beginning around social sustainability. If you're not aware, most of the world's healthcare supplies are made under child labor and very unsafe, unethical, breaching all human rights type of issues. And so there's work going on around fair trade and healthcare supply, because we're greening up things and doing good for the planet, but that's at the expense of child labor and people losing their lives and limbs simply for making gloves and surgical instruments and, the things that we use in healthcare education as well as healthcare practice. Well, then that's not sustainable as well. And there's a really good video on that called on YouTube, Human Cost of Healthcare. One of the links in the slides is from some work going on there around ethical procurement. So in our healthcare education practices, we should also be procuring in a way that's socially sustainable. So I'm just to time, so a little bit of time for questions, but thank you very much. I will stop sharing my slides and really hope that was useful for everybody.
Thank you, Heather. That was a really, really fascinating talk. You actually have two questions, which I will read out to you now. The first question is, Bhutan is the only country in the world that is carbon negative. What can we learn from their model for healthcare?
Do you know, I did know that. I'd heard that a while ago, and I actually saw that on a social media thing about 3 days ago. And I thought, I'm going to look that up. What's Bhutan doing that we can all do? So I confess, I don't know. The other thing is carbon footprinting is a bit of a minefield. There's no standard methodology for at least apply to healthcare. It depends on how you do it, and it's quite complicated. So it's difficult when you look at net zero around, you know, how is that meaningful? But yeah, great question. I'm gonna dig around. If anybody else has the answer to that, then please do share. But I think, you know, and there are pockets of really good stuff going on. Another place doing lots of great work is Holland. If you look up Holland's sustainable healthcare things from a healthcare perspective. But
Brilliant.
Bhutan, I think, is for the entire country, isn't it?
Brilliant. Thank you so much, Heather. That was really, really fascinating. We've got another question. Well, in fact, two questions from another individual. Could the COVID-19 pandemic, the COVID-19 pandemic had a big impact in reducing the process of implementing sustainable healthcare, such as reducing PPE equipment within clinical practice due to fear of spreading or contacting the virus? So I think what they're trying to say is, could that have been impacted because of that particular fear? I think that's the question that they're asking.
Yeah, and we're still. I was teaching this type of session to some University of Brighton students quite recently, and did the whole talk and really focused on gloves because that's what I was asked to focus on. And, you know, right at the very end, somebody said, I know, but I need to wear gloves every single time I touch a patient. I can't not, you know, since the pandemic. And I think there's a lot of, I thought that was really interesting. And actually both the first two keynote talks around the psychology aspects of healthcare education, as well as healthcare practice. And where does that come from? Because you can bring all the science you like. I think the pandemic, as it played out, was a really good example. It's not just about the science. The science can be sitting there. Data can be sitting there. It's about how you interpret that data and what it means to you. And I think we're still trying to figure that out. Certainly in shops, I was in a shop the other day, somebody was wearing one glove, not two, one. And I just thought, who's protecting who from what? And now that we know so much more about COVID, I mean, at the beginning, when we didn't know anything about it, I think the sort of rash kind of, remember the days when we were wearing 3 pairs of gloves and then you take one off and then we're running out of gloves, so we're cleaning them and, you know, all of that. We didn't know what COVID was. It was a global pandemic, you know, but as we got to know more, and even in our simulation rooms, we were quite slow to start undoing practices that we knew that the healthcare sector wasn't doing once we found out more about it being respiratory borne, et cetera, and things. But I think it's really hard to unpick that behavior change and cultural norms. And so that's why sometimes top-down strategy around, you know, this is just how it is. This is the mandatory policy. And then once you start a wave, it's like dominoes, and you get a few people doing it and a few more people doing it, a few more. But I think PPE is a hot topic. Lots of waste from PPE. And I know your background, you know, isn't it, around infection diseases and antimicrobial resistance? I haven't mentioned today, but it's another really interlinked, and lots around pharmaceuticals and how we use them. Because nobody's saying we're not going to use gloves, we're not going to use antibiotics, but could we use them in a way that's more sustainable, that's actually better for patients and better for the planet? Because when we start to look at stewardship in particular, we find sometimes less is more. Less is better for patients sometimes, not always. It depends what we're looking at. And the models that I mentioned, they're based on 4 principles of sustainable clinical practice. First being prevention. So all the work we do around health promotion, preventing complications, that's the most sustainable thing we can do as clinicians, because then you prevent the hospital admission, you prevent the disease from exacerbating, et cetera. The second being patient self-care. So where patients and family can, you know, a whole movement around self-care, digital transformation, all that type of stuff. Third, around lean pathways. So that's reducing waste where possible. And fourth, finally, around low carbon alternatives. And you'll find even in that circular economy model that's embedded into lean pathways, things like recycling are kind of at the end, you know, finding the low carbon alternatives are kind of at the end. What we should really be prioritizing is the public health, the health promotion, preventing people from being sick, and then you don't need all the other things as well.
Okay, great. I mean, we do have one more question, but I think what I'll do is I'll send that to you, and you can perhaps answer it in your own time. So I think
Can I just say thank you to the students for helping me out, because I couldn't see the chat, and I sent them a message not long ago, actually, I'll confess, saying, hey, how about everybody populates the chat with all the links that I know you've been doing.
Yeah, they were doing that. They were definitely doing it.
So this is an example of students actively engaged live in the moment while you're talking about your research of both the two keynote speakers, actually.
I'll remember that one for next time. I'll do that.
Yeah, and hopefully, and I think they'll, you know, enjoy the rest of the conference as well. I was thinking about that, particularly the stuff you were saying, Louise, about transitioning into, you know, I thought, oh, this is brilliant for the students to be hearing this. So.
Yeah.
So big shout out to the University of Brighton students. Thank you very much.
Yeah, I was actually going to mention that as well. They've been sharing all the resources, so that's been really, really nice. And you've had lots of nice messages thanking you for your talk, which you can
Great.
look at
Yes,
afterward.
I'm going to try to join on my way to Heathrow Airport. I'm so sorry for catching in a plane on the day. I'm fine talking about sustainability, but it's also an example of we've still got to live our lives and we've still got to do things, right? So, anyways, I hope you all enjoy the conference and thank you so much for the invitation.
Thank
And do
you.
be in touch to collaborate. This is all about collaboration.
Definitely, for sure.
Thank you so much. So I think with that, we can go on to our break. So we've got a half an hour break now, so you can get your teas and your coffees. And we will be coming back at 11:30 Gibraltar time, which is GMT +2. So I look forward to seeing you shortly. Thank you. It's wonderful to have you all here today. I'm very excited to present our next speaker, Sam Willis, who is a PhD student and is currently head of paramedicine of Charles Darwin University, Australia. Sam qualified as a paramedic from University of Hertfordshire in the UK in 2004, qualifying with a BSc Hons in paramedic science. He then spent 10 years working in a range of clinical and educational roles, such as ambulance paramedic, solo response paramedic, lecturer practitioner, and training officer, before working in Oxford as a senior lecturer in paramedicine. Sam is lead editor for the popular paramedic text Fundamentals of Paramedic, a systems approach, which is currently in its third edition and sells in over 44 countries worldwide. And he has been teaching fellow of the UK HEA, Higher Education Authority, since 2009. Sam is nearing completion of his PhD, where he's completing at the University of Adelaide in Australia. The title of his talk is Work Integrated Learning and Virtual Reality Communities of Practice. And with that, I will invite you, Sam, to share your slides and begin.
Thank you very much indeed. Wow, definitely a grandiose opening. Thank you very much. Just give me 30 seconds just to try and share these. I should have got these ready at the break, but I didn't. So just while I'm getting these ready, it's fantastic to be given this opportunity to talk about my research. And I genuinely believe that anybody who's done research, whether it's part of an honours, a master's, a PhD, they genuinely do have an ethical and moral responsibility to disseminate the findings. So it's really great to be given such a decent, high quality forum to be able to share my findings. And I don't truly know my audience, but I can see one of my students, Tanika's in there. Hi, Tanika, which is a really good way of encouraging our students to do their research. And I can see my PhD supervisor as well. But I'm hoping that different parts of the presentation might resonate with different audience members. So just give me 30 seconds just to share. So can you see the presentation on full screen?
Yes, indeed.
Yes, we can see that now.
Fantastic. Thank you very much. Okay, so I'm going to need to talk a little bit quickly because when I did the practice run of this, it came out at about 40 minutes. And I know that your bums will get sore. You don't want to be talking about virtual reality for 40 minutes. So I'm actually finishing the study with the University of Adelaide, but I actually work at Charles Darwin University up in the Northern Territory here in Australia. And the study that I undertook was multifaceted, and there were lots of moving parts to it. So what I've got in this presentation is a summary of what I believe are some of the key moving parts, namely the voices of the students and the voices of the university lecturers who prepare those students to go and take part in work integrated learning. And for those of you who are not familiar, the main aspect of the study, that one of the phases of the study drew upon Levenwenger's communities of practice. So I talk a little bit about this social learning theory known as communities of practice. So of course, the research setting was within paramedicine and student paramedics. For those of you who are not familiar, paramedics both in the UK and Australia share registration and therefore they share similar regulatory standards. And that means that the public can be absolutely confident that those people attending patients in their worst time of crisis, using that title paramedic, truly are qualified and they meet the exacting standards so that they can provide high quality, safe clinical care. Now, the interesting thing about paramedic practice is that we no longer only work on ambulances. So paramedic practice nowadays is broader, and it means as a paramedic, you can work in community settings, you can work in GP super clinics, you can work on cruise ships. So we've got this increased confidence being placed on us by policymakers, by the public, and by a range of other senior people. Now, to become a paramedic, certainly in Australia, you need to complete an approved program of study. I know that's the same in the UK, but the biggest difference in Australia is that predominantly the qualifications are university-based. They're generally speaking 3 years in duration, and they lead to a bachelor's degree. So they're university-based bachelor's degrees. There are, of course, some variations to that. As part of the degree, students will undertake work-integrated learning. Some people call it clinical placement. And of course, we know that during that clinical placement, that's where the students try to bridge that awkward theory-practice gap that we know is really difficult to bridge. You know, the students come into the classroom, they learn the cognitive knowledge, they have some simulated learning where they bridge some of that cognitive knowledge and apply some of that learning. And then, of course, it all becomes so much more real when they go out into work-integrated learning. And of course, I've used the typical stereotypical ambulance picture here, but we know that it's not just emergency ambulances now. So some authors will say that work-integrated learning is by far the most important aspect of a student's learning. And that's because the type of learning you get from work-integrated learning is different, and you cannot be simulated in even the most high fidelity situations, because you're with real people, with real life situations who are in real crisis, who are really unwell. And of course, high fidelity mannequins and really well-written case studies are all good and true and fantastic, but it doesn't come close to the real deal. And of course, what we do know is that work-integrated learning, when it's carefully designed, carefully planned, when the mentors have the most appropriate support and the most appropriate training, it's an opportunity to guide the students and to take them from that classroom-based simulated learning and help them to bridge that theory-practice gap. And of course, according to the text of the Tertiary Education Quality Standards Agency and other authors, the work-integrated learning environment exposes students to their future professional culture, which is something that's extremely complex to navigate. So a little bit of a background to the study. So student paramedics experience significant challenges associated with WIL. And to be completely honest with you, it doesn't matter whether you're a student paramedic or a student nurse or a student doctor. As with any research, you have to do a literature review. And what I found within the literature was that the challenges faced in student paramedics, the social isolation, the problems with the theory practice gap, the mentoring, the lack of confidence, the lack of experience that feeds into the lack of confidence. It doesn't matter whether you're a nurse, a paramedic, a doctor. All of these healthcare professionals all experienced the same challenges. So you can quite easily replace the word student paramedic with student nurse, student doctor, student physiotherapist. And the big one for me is the social isolation. More and more frequently, we're seeing evidence that says that social isolation is not just bad for education, but also bad for your physical and emotional well-being as well. So let me tell you a little bit about the study then. 3 primary aims, designed in a study using 2 phases with subphases. The first aim of the study was to identify exactly how student paramedics were prepared for and supported during work-integrated learning by their home universities. Ultimately, when a student goes out into practice, it's their university that is responsible for everything that occurs there. They have to set up the relationships, they have to set up the documentation, they have to do the check-ins with the students, and when things go wrong, it's the university that has ultimate responsibility to navigate the student through this. So a good starting point was to work out exactly what were universities doing for students. The second aim was to look at the contemporary challenges facing student paramedics during work-integrated learning. Some of the literature that I was looking at was starting to date, meaning that we couldn't be completely sure that the challenges reported in the literature were even in existence. And the outcome of that is it absolutely is. And of course, the final stage, which was by far the biggest stage, was to establish the utility or the usefulness, the ability of Levenwenger's communities of practice held in virtual reality to help to prepare and support students for work integrated learning. And to be able to respond to these aims, there were a number of research questions. And I broke it down into two main phases. Phase one, which was a national context. I sent out an online survey to universities across Australia to ask the universities, how are you supporting your students? How are you preparing them? And then within that phase, subphase 1B was asking student paramedics, tell us about your experiences of work integrated learning. Once we had that information, we were able to then look a little bit more closely at the local context. So what are paramedicine students' perceived strengths and challenges of work integrated learning? And we established this through face-to-face and online semi-structured interviews. And of course, the major phase, which was the use of the virtual reality communities of practice, which were really exciting, by the way, using a head-mounted display with virtual reality goggles using the MetaQuest 2 and having students physically transported into the community of practice, into a vibrant and lively and exciting environment. The whole thing was hugely fascinating. I'm going to tell you about some parts of this in a moment. And of course, the questions are, how do communities of practice help students prepare for and manage the challenges that they face during placements? What are paramedicine students' perceived strengths and challenges of actually attending virtual reality communities of practice? How does virtual reality itself as a technology impact students taking part? Because we know it's the participation where all the good stuff happens, all the learning, all the making sense, all of the higher level thinking comes from participation. And of course, I had to throw in there anonymity as well, because it wasn't complex enough. So the idea behind having anonymity is that if we were to take away all your names and take away your pictures, the idea is that there was a perception that there's less risk associated with participation. And again, the results of that were fascinating. Certainly wasn't anything I could have expected. And of course, finally, how do virtual reality communities of practice affect students' work integrated learning experience? Because that's what we're trying to achieve. That's just what the study design looked like. It was a multi-phase explanatory sequential mixed method research design, which saw the quantitative categorical data being collected first and foremost to set the scene and to paint the backdrop to the problem, followed by the qualitative data to allow the voices of the participants to be heard before interpreting the data. And of course, no PhD is complete without considering the philosophical lenses that you are actually viewing the study from. And of course, because we are using people at the center of this study, it's an interpretivist, social constructivist dominant study. That just means that it's people coming together to share their experiences, to make sense of complex situations and to create new knowledge together. And in terms of the methodological design, we used an eclectic approach using descriptive and transcendent phenomenology. Phenomenology is a research approach which focuses and specializes in the lived experience of the people. Action research allowed a structure, plan, act, observe, and reflect allowed some structure within the study. So as I was observing some fatigue and some other bits and pieces going on in the study, I was able to adapt based using the action research cycle. And of course, communities of practice as both a method and a methodology. And because the study was undertaken using virtual reality, cyber ethnography was another aspect of another methodological aspect. In other words, how were people leaving their real world values behind and creating new values within a virtual reality space? This is just showing you that there were two phases, phase one, phase two. Phase one asked the university lecturers about their experiences supporting and preparing students. Phase 1B are the students. Phase 2A are the local students. Phase 2B is the participant observation, myself as the researcher, observing how people were taking part in the study. And of course, a focus group to evaluate the whole thing together. So inherent in the problem with qualitative research is this idea of trustworthiness. And of course, using Braun and Clark's 2012 thematic analysis, I used a mixture of deconstruction and thick description, ultimately immersion and repeated immersion, and in combination with reflexivity, saw the study's trustworthiness enhanced And of course, none of this could have been possible without my PhD supervisors, who helped me to triangulate some of the data that I was producing in my study. For example, when I generated the codes and the themes. In terms of this slide, it's just telling you that we had constant access to the data. These two Qualtrics surveys that we use in phase 1 was readily available, and it's still available, so we can revisit it time and time again. And in terms of accessing the observations of the participants in phase 2, we had access to the data that's built into the actual head mounted display itself. Ethics was approved by the Adelaide University Human Research Ethics Committee, and I obtained a small research grant from the Australian Paramedical College for the purchase of 8 MetaQuest head-mounted displays, which look like this. Just one slide on communities of practice, because I'm not entirely sure if anybody in the room's ever heard of them. But the reason I chose communities of practice is because it's a paradigm that's intentionally designed to bring like-minded individuals together to share, reflect, discuss, unpack problems, be vulnerable, imitate, and to participate. So it was a real fit to my research, because in my research, people were at the center of it from within each of the phases. And of course, the theoretical basis is the domain, the community, and the practice. The domain is the paramedic education, the community are the students, and the practice is the work integrated learning. So just one final comment about running the communities of practice. They're actually quite difficult to run. So before I entered the study, I actually had some practice running communities of practice in a range of different settings, with students at undergraduate level, students at diploma level, at faculty-wide levels at universities, and at a vocational level as well. And all of those experiences, on top of reading and learning and observing other people, they positioned me well to be able to run these communities of practice. So let's get down to some of the data then, because this is where the interesting stuff happens. So survey questions in phase 1A. So this is me asking university lecturers, tell me how you prepare your students for placement. Tell me how you support them. Tell me how you consolidate their learning. In your opinion, is enough done? And can you explain why you say that? Is enough done to support your students? Is enough to prepare your student? Interestingly, from the data, there were, out of the 14 universities, only 6 universities responded to this data. You have to remember that when I undertook this data, there was a global pandemic occurring. So the priorities of the universities were to get through the pandemic. But overall, I was satisfied with 6 universities because the data they provided was actually very strong and high quality. Out of the 6, 3 universities did not agree that they did enough to prepare their students for placement. And they also agreed that they did not do enough to support their students during placement. So I thought that was fascinating. Out of the qualitative data, we found 4 main areas: collaboration, educational design, technology, and clinical placement models. So these were the areas. And by the way, I decided to combine the data. So when we talk very, very briefly and very quickly about collaboration, educational design, technology, clinical placement models, this is both for the preparation of and support of students. So just a couple of statements from the data. Key adjunct or professional staff are contact points for students in their placement locations. So that's good that University M gives students contact points, because there are occasions when students need to take advantage of that. We have an amazingly talented clinical placement officer. So you can see that it's not only the university lecturers themselves who have that responsibility for preparing and supporting them. Educational design was by far the biggest theme. So when you say to the lecturers, how do you prepare your students? The biggest theme was educational design. And as you can see here, just a snapshot of some of the things they were saying. Work integrated learning has become an embedded feature of much of our curriculum design and delivery, and features in many guises. This varies throughout the undergraduate experience. And then there's something here about scaffolding, starting from a certain level and then benchmarking and getting more and more complex as the students go throughout the course. The learning is scaffolded throughout the program. It builds on elements of the working environment, for example, scene dangers and mitigation strategies to communication techniques and information required by other emergency services or hospital staff for outpatient interactions. Something there again about scaffolding. And then there's something in there about the intensive block of education where students attend for 5 days, 7 days, instead of splitting the education throughout the semester. Of course, technology features in there. We've taken an innovative approach to supporting students involved in technology and a joint duty of care. And we prepare students through a variety of forums. This includes pre-placement preparation seminars, online access to will requirements, and handbooks that support students in preparing for clinical placement. This is superficial preparation and needs improving. Clinical placement models then. So clinical placement model is any structure used to place the student. So whether that's you're going to spend 4 weeks with the same mentor, or 4 weeks with a different mentor, or you're going to have 1 day here, 1 day there. That's just what we mean by clinical placement models. And it says here that our university has a significant number of will blocks. The block model is very popular with clinical placements, which all provide orientation for the next. And students are supported through site facilitation. So people go out and visit students in 3rd year. And I don't know why 3rd year. Okay, some of the challenges then that universities have had. We don't invest in grassroots preparation and support. I feel we could prepare students better. We just don't have the time, the resources, or the funding to do it appropriately. Several weak links in the chain leads to a variable quality of placement experience. University will team to prioritize the operational and logistical focus of placing students within industry ahead of the meaningful learning that is sought from the event. We know that clinical placements are extremely complex, and you have a clinical placement team who have one set of priorities and an educational design team who have a different set of priorities. Ultimately, it's the student who takes on board that experience, so we have to do better. There are always limitations with funding of sessional staff, etc., that can impact the amount of clinical time and preparation a student has to prepare. And we do the basics to get the students on placement as a requirement of our accreditation, but we don't invest in grassroots preparation and support. I feel we could prepare the students better. So some very honest and open admissions there from universities across Australia. Now we move to the student focus, and embedded in these questions, you've got some questions that ask for quantitative data, categorical data, and also asking students to rate how they felt about their experience and why they gave it that experience, that number. And from the data, 3 main themes have emerged: the role of the mentor on the student experience, the challenges facing student paramedics during will, and the clinical placement models all impact students. So the benefits of will then, I always enjoy reading these because this is what we want our students coming back and telling us. They included me in patient care. So we talk about isolation earlier on. This is the complete opposite. We know that when there's no isolation, the students have good experiences. They included me in patient care and instructed me on issues I may not have considered in normal day-to-day practice. I feel as though I have had a good clinical supervisor throughout my student journey who allowed me the opportunity to think, question, practice, and provide feedback on my actions. That's fundamental. I felt the learning experience in a supervised environment was beneficial. To see the job in action gave me an opportunity to model my own practice or imitation, give depth to the skills in which I have learned to date. Mentors model behaviors, and then I get an opportunity to then follow that. So again, imitation, really powerful. That modeling and demonstration ultimately during the time that I had learned something, and then I can apply it and get checked off as a skill that I have both observed, led, and then applied. So again, there's something in there about scaffolding. While neither of the will blocks I have done were in the field of paramedicine, they both had significant learning opportunities and gave me a good perspective of healthcare as a whole and the big picture of what people are experiencing and where they need help, not just in an emergency. So this person, who I've given the name Nick, is demonstrating real accountability for their learning there. I felt like I learned so much more on placement and was allowed a time to really solidify my career choice. So let's take a look at some of the challenges then. During the placement, I felt very much left on my own, despite the 2-week reflections and mentors reports. I found my placement extremely beneficial to my knowledge base, but often felt isolated in my experience, as all my peers were on different schedules and we would often not get many opportunities to talk about our respective experiences. It felt like I wasn't wanted at my placement and there wasn't really anything for me to do, even though I sorted out also wasn't particularly relevant to my future work. Periods are short, so this is clinical placement models now. Periods are short and not all students get the same experience. Some only get to watch where others are asked to complete tasks. There's no standardization regarding will. A few people on placement were unwilling to accept or allow the student to undertake certain skills that were part of the placement. But I found myself holding back the little question that I would have asked another mentor. I would ask them, and then I would actually go to an old mentor. If I had a big question, I would throw up an old mentor who I knew was, wanting to do the job. So there's something in there about the different type of experiences they're getting from mentors and the importance of the lifelong relationships with someone you deem to be your lifelong mentor. Little professional engagement from preceptors, either due to poor attitude, workload pressures, or both. So for those of you in the audience who are not paramedics, but you're going on placements, I'm sure that some of this stuff resonates with you. It's not completely unique to paramedicine. And I'd love to have this chat just very briefly at the end if there's anyone willing to have that. Lacking in confidence. This is something I hear all the time. Speed and confidence in the early days of the prac. Overthinking things, which is not necessarily a bad thing, before deciding to act upon the history and presentation of the patient. I also found a profound challenge for me was being confident in my assessment and treatment of patients with paramedics watching over me, therefore potentially affecting my patient care negatively in some respects. And the clinical challenges I faced were mostly related to a lack of knowledge and experience. I took a lot longer to perform certain skills than my preceptor who's been in the job 10 years. Well, that's completely okay. It did, however, make me feel as though I was holding up patient care and probably shouldn't be leading treatment for the sake of my patient. Talking to different aggressive patients, working with children, long transport times, and they're trying to make small talk and having to see some unsavory things, e.g. children with clear drug-affected patients. Applying theory to practice, the clinical challenges I faced were mostly related to a lack of knowledge experience. This slide is about applying the theory to practice. I had my first placement the week after my second week of uni. Some of the paramedics expected me to know more than I did. And of course, this one's always fascinating. Other students, the impact that other students have on those students who are performing well and doing the right thing. Not enough emphasis is put on the psychosocial aspects of students on placement, such as leaving ego behind, which often comes with paramedicine students, being willing to learn and to be of service, etc. On demeanor and how to make patients feel safe with you without you even having to open your mouth sometimes. Gaining patient trust is huge and the most important task of our role, yet no emphasis is put on this during our training prior to clinical placement. And then working in a team with students who are incompetent and clearly hadn't read the information beforehand was a nightmare, and no one wanted to hear our worries. Okay, so then we get to the major part of the study. In phase 2B, 8 students attended 6 one-hour virtual reality communities of practice. This number was intentionally designed because there's a quality versus quantity balance. And the community consisted of students in years 1, 2, and 3. Again, that was carefully constructed. Levenwenger will use the language old-timers and newcomers, with the old-timers being the students who are in their top years and the newcomers being the first years. So here's a couple of screenshots of the environment that students were being placed into. And this is a more formal environment. This is a virtual teaching classroom. But what you immediately notice is the vibrancy, the bright colors, the light. The students have also chosen to create their own names. So there's a level of anonymity, but I'll tell you what, they tried to move heaven and earth to try and work out who everybody was. And they almost learned who everybody was. Just a couple of the first years had complete anonymity with the second and third years, but the first years knew each other. They've given each other, they've chosen their favorite characters from the TV to give themselves a face. They've given themselves anonymous names. But also what you can see from this slide is the functionality of virtual reality. You've got Post-it notes, you've got coffee, you've got a journal article. Are there any health benefits to a cold shower? So the functionality, the participation, the immersion is absolutely there. This is actually a campfire. You can just about see the campfire in the background where the logs are. We've got this thing called a spawn point, which was a funny situation in its own right. I created the spawn point, and the spawn point was where the students were supposed to come into the room, wherever you put the spawn point. And halfway through the presentation, I was saying, everybody come over to the spawn point. And nobody was saying anything. And I said, can't you see the spawn point? It turns out they couldn't see it. I was the only one that could see this thing called a spawn point. But anyway, another example of a more relaxed environment. And the students loved the noise of the fire. It was very relaxed, and it broke down barriers. It got rid of some of the formality. As you can see, lots of love hearts. One of the students was even drinking champagne, lots of coffee, lots of references to the Matrix. remembering that part of this is about community. Remember, a domain, a practice, and a community. So a part of this is about creating that community so that learning can just naturally happen. Friendships formed, and they are still ongoing today. And of course, it's learning. Learning is at the heart of all of this. And I observed a difference in the way the students were behaving when they were socializing versus when they were learning. Once the learning switched on just naturally and organically, the students' attention went from relaxed to, okay, you've got my attention, I'm now listening. And there were no set procedures for achieving that. It just naturally happened. So let's see what the students said about the study then. So I think it was good to have a chat to other people that I probably wouldn't necessarily bump into or experience their shifts, colors, and things like that. So this student Kohler, he was saying that he wouldn't have otherwise had the opportunity to talk to people. And remember, this is the social isolation part that we're actually addressing now. It helps to know that you are actually not alone in this. And I've really enjoyed the communities of practice. I think it's nice to be able to come in and speak to everybody. Peer support, hugely, hugely important. I didn't get on with my first mentor, but 2 years later, I'm still here. But I've also had great mentors. So what you're looking at here in these statements are second and third years supporting first years. First years, they were raising real concerns and anxieties and worries about going on their very first ambulance shift. And you've got second and third years giving them lots of real tips on how to perform well. And also listening and empathizing. And as you can see here, student Jim, spend your first shift watching. If you're stuck, ask for help. Mentors are there to guide you. Psychological safety is always important in education. Students mentioned that it felt like a safe space that I'd created and everybody was comfortable to talk about things. And even student Colot at the bottom was saying, I feel like I've said a few comments which probably crossed a few lines, but I think everyone sort of quietly respected everybody in general. Every time I come on here, I feel like what I'm saying is understood and kind of gets heard. Something you don't necessarily experience in placement all of the time. Now, the anonymity was interesting because I had more grandiose ideas of what it was going to be, but it didn't turn out to be like that. But that's part of bracketing, right? Putting your own needs second, third, and fourth to what's going on. But being in like an anonymous sort of situation, you might be a bit more sort of open and more likely to take a risk and say something. Somebody's put that they liked that people couldn't see their faces, so they didn't have to spend an hour getting ready. You could just put the goggles on and boom, there you were in the room. And then somebody got a student cohort got a real benefit from meeting people virtually. There were other comments as well. Students were talking about the time and cost of having to get in your car and drive across to go to the university to do this face-to-face versus you finish your shift, you can have a quick break, stick the goggles on, and you're all automatically there. And of course, here's 3 examples of how virtual realities communities of practice impacted placement. So again, this was during the COVID times. One student prepackaged the COVID swabs, which was a direct result of students sharing experiences on ambulances. And they make it very clear what they did and how they did it. One person prepared the individual RAT tests, and another student, number 1, tried the green bag thing. What this was students creating to try and reduce the amount of equipment that was being taken into the house, which could get infected. They tried to create a bit of we had a bit of a laugh and a joke with it. We called it a purse. You know, we talked about students putting the tympanic thermometer or the blood glucometer in the purse and taking the purse into the house. So there's evidence there that it really did impact placement. So I kind of like the reflection side of things, and that's interesting because students never say they kind of like the reflection side of things. And looking back and thinking, they're usually the last things that, in my experience, tell me if I'm wrong. This VR session has made me look back into the past and think about how I've developed and come along, making them proud. And I've really enjoyed it. I think it's nice to be able to reflect on where you used to be when you're hearing about where people are now in that first year. So a couple of limitations then. One student reported they would have liked more practical scenarios, although that was never the intention of the study. It was always a community practice about talking, thinking, reflecting. The cost of the VR headsets can be off-putting to some people, although the Oculus Quest 2 have come down in price now. Hosting communities of practice does require quite a bit of groundwork. Time is required to set up the head-mounted displays and the spatial app, and some students did require coaching through the nausea, but it ultimately went away, and that's predominantly got to do with the internet speed. So as a conclusion, then, students face a barrage of complex issues as they attend work integrated learning. These challenges impact their experiences and potentially their outcomes. Communities of practice held in VR are one solution, which has been shown to bring students together, to allow them to create solutions to these problems, which include reducing social isolation, engaging reflective practice, role modeling and imitation. VR COPs are transferable to all healthcare professionals and business, because I use communities of practice at the university where I work, whereby students enter industry and they can support both students and mentors. Any questions?
Thank you very much, Sam. That was really fascinating. You're doing some really great work. Unfortunately, we don't have time for any questions at this time. However,
That's great.
Attendees are very welcome to write questions in the Q&A section, and we can then send them on to you, Sam, if you're happy to answer.
Absolutely. That's absolutely fantastic.
Lovely. Thank you very much.
Thanks, everyone.
Okay. Great. So I think I will present our next speaker now, Dr. James Viñales, who is the head of School of Health Sciences at the University of Gibraltar. James qualified as a registered nurse in 2000 and then completed a BMed Sci nursing in 2001. Both qualifications were attained at the University of Sheffield. James has worked in England, Gibraltar, and Australia as a registered nurse before pursuing a career in higher education. In 2008, James completed his MA in Nursing Studies and Education at the University of Brighton. James worked as a senior lecturer in nursing at Birmingham City until his return to Gibraltar in 2012 as senior lecturer and principal lecturer in collaboration with Kingston University and St George's University of London. In 2019, James completed his MSc Leadership and Management with Kingston University and Royal Holloway of London. The title of his talk is The Importance of Collegial Mentoring in Work-Based Learning, and I will pass the mic over to you, James.
Many thanks, Dr. Lyons. Right, good afternoon, good morning, good evening for those of you in other parts of the world. My talk, as Leon mentioned, is the importance of collegial mentoring. I first want to start off with the reason why it's G mentoring. Was obviously my work, as you'll see in a minute, is based on collegial mentoring, and that G hyphenated is why I've called it or renamed it G mentoring. So that collegial mentoring, or that G in mentoring, stands for collegial. So, and that I think is quite important. So overall, I want to place this into context before I start, which is in Gibraltar itself, there is no mentor standards, and we for many years have followed the NMC in the UK. And obviously at the time, the NMC had the SLAPE, which in 2018 changed to the SSSA. Now in Gibraltar, we kept the SLAPE as opposed to introduce the SSSA. And there's varying reasons for that. Predominantly because our mentors could spend 40% of the time with our students. And it's a model that worked relatively well for Gibraltar, considering its size. So obviously, one of the things I want to look at as part of my PhD was look at developing a local standard for mentoring for the registration board in Gibraltar. And that's already in discussion with them. And adding more a G mentoring approach into that standard, which currently doesn't exist. So overall background with regards to mentoring in general globally, there's very little research done in Gibraltar from a mentorship perspective. I think mine was the first one. And I think Louise, since Dr. Lawson earlier mentioned about some of her work with students. So particularly in Gibraltar, or globally, should I say, there's some of the mentor issues that were seminal as part of this work. Mentor preparation, for example, in the literature raises key questions or key issues, predominantly within mentoring in general. For example, failing to fail, the emotional support for mentors when dealing with challenging conversations or challenging students, assessments, as again, true mentoring, contextualized, doesn't really have assessments, and obviously providing feedback and feed forward for your mentee. We also look at typically, for example, with my background in the UK and Australia, and working in certain healthcare providers in the UK and stuff, the support typically comes from practice placement managers or clinical educational leads, which is great to have them in place. And one of the things that Gibraltar hasn't got is it hasn't got either or. But again, we've got very strong link with the lecturers, with the mentors, and I think that works quite effective. However, the literature does suggest that there's a lot of issues with regards to mentorship support by practice placement managers or clinical education leads or clinical education facilitators. So mentor support has been linked to mentors being unsure about the assessment and consequently failing to fail, which is a big issue when you start looking at mentors in practice who are actually judging the competencies or proficiencies of students. And if they're unsure about the assessment or unsure of their role within that, it raises quite a lot of issues. And another point from the background itself was that mentors wanting more support when mentoring students. As you can see, there's an array there's a plethora of research that's been covered as part of mentoring in the past. More recent, the SSSA start looking at coaching, more coaching models being, especially in the UK, being introduced in the UK, like CLIP and Plan, which are currently being used by some places in the UK. But overall, from my experiences both as a mentor and as in higher education, it's looking at mentors requiring more support. Hence, that's where my PhD originated, or my ideas originated from my PhD. So looking at the research itself, the PhD the data was collected in Gibraltar healthcare context. So as you can see, Gibraltar from the background, and Gibraltar is not very big. So I pointed out in areas where the data was collected. Those were the 3 points where students are sent into practice and where our mentors are based. So overall, I interviewed 32 individuals, semi-structured interviews. So it was qualitative. 87.5% were females and 12.5% are males, which statistically from male and female correlates to both the NMC and the Gibraltar Registration Board in relation to males to female ratio. So I developed my own tool, the Viñales tool, which was based on thematic analysis by Braun and Clark and Smith and Larkin's IPA. And that's how I analyze my data. My theoretical thinking was phenomenological, so interpretive. And what I tried to look at was the research aimed to explore the preparation, very broadly the preparation, for example, stage 2 mentors, as they were used to be called, or mentors, formal mentors, had to be prepared generally or typically via a program of study, a course of study via a HEI. And that still happens in Gibraltar. That preparation formally has to go through the University of Gibraltar, and previous to this, through Kingston and St George's University of London. So that's the formal aspect. And one of the things I wanted to explore was not just the formal aspect of the mentoring or the preparation for mentoring, but also any informal preparation, anything that the mentor or the registered nurse would be doing to get them ready for that preparation, for that formal role, and not just the program of study. And more importantly for me as part of this is how does that correlate to the support for mentors? Because one of the things in the literature and from my anecdotal evidence from working externally and locally in Gibraltar was that mentors require more support when working with students, especially when there were any doubts about the student's competency or proficiency or professional values. So anything that the mentors felt were issues, I think a lot of them felt more support. And traditionally, as I said earlier, you would then escalate it to the ward manager, or escalate to the practice placement education, and issues like that, which I wasn't sure whether that would be the best solution for it. So my findings were 3 main themes that came out of my funding. One was a collegial mentoring in practice. And this was very much about the mentors learning from colleagues, basically, or working with colleagues. So the preparedness for the mentoring role, and how the registered nurses on the wards or the mentors on the wards really valued and really wanted that support to come from their colleagues. From literally, I can turn around and say, actually, you were on shift with me yesterday. How do you think Sam did? Or how do you think Sam is coping with this? As opposed to escalating it. And that for me was quite unique, really, because we assume that they're going to escalate things further, for example, the ward manager or further up. But actually, a lot of the mentors, what they were telling me locally was actually, I go to my colleague in practice. And that was huge, I think. So obviously, it's something that's done quite informally, but the mentors are there supporting those mentors in practice. There's also the how some of them felt and preparedness for the mentor role. For many of the students or the mentors that I interviewed, there was quite a high level of anxiety related to their role as mentors, and that was under the umbrella of unpreparedness. A lot of them, even as newly qualified mentors or as mentors, they were quite anxious about their role in case they would, am I getting this right? Am I doing this properly? Should I be doing this instead of that? And for many of them, it was quite a negative experience, and not such a positive one as mentoring normally is associated with. So generally, when you look at a mentor, you start looking at someone who's going to guide you, who's going to support you, who's going to empower you, give you the tools to develop further as an individual, as a student nurse during the 3-year program. But for many of them, it wasn't such a positive experience, which I thought was very interesting, for that their perspective came through. So that also highlighted the element of support for them in that element or that component of their role. And collegial support in practice, this is what they felt, a lot of the mentors felt from that theme, well, they felt that they would go back to what was most beneficial to them were the workplace colleagues, those colleagues that are in practice. And I think for many of us, maybe we take that for granted, that in practice, actually, your colleagues become such a huge level of support. That collegialness that you have in practice, especially if you work very closely with them, you've been working for a while with them, you trust the judgment, you trust their ability to work with you, you trust their professionalism, and you're able to say, actually, yeah, if they're saying this, I completely trust them because I'm aware that they're quite professional in their job role. So they're not going to say something to me out of spite. It's going to be actually quite professional in what they're saying. So that's where the three themes originated from. So continuing on from that, part of the mentoring approach that I started looking at was, or two main functions that the collegial approach to mentoring has, is how the informal mentors learn the ropes of the formal mentor's role by working with the formal mentors. For many individuals, for many registered nurses, they're able to work with their mentors and supporting them, but at the same time, giving them like an associate mentor or co-mentor, as it's generally referred to. So associate mentor or co-mentoring, where actually the registered or formal mentor relies on colleagues to work with them whilst they're not on shift, whilst they're away. And for many of the informal mentors, they felt that that was quite important for them in their preparation to become a mentor. Why? Because they were able to learn the ropes of what the role actually was. But interesting enough, it was without having to complete the assessments or documentation, which a lot of individuals hate. One of the things that mentors were not happy with were the amount of documentation that has to be completed as part of their role. The nurses on the ward, they've got a workload to look after, they've got patients to look after, they've got a student with a mentee who they're mentoring. All of a sudden, there's documentation not only from my patients I need to do, but also from a student perspective. So for many of them, being that associate mentor or co-mentor or that collegial mentor meant that they didn't have the responsibility of the assessments or therefore the documentation. So we see from the screen, from the image that I've got in front of you, the collegial mentoring itself is that informal relationship from that collegial mentor in the middle. So the formal relationship still exists between the mentor and the student, that mentor-mentee relationship. What the collegial mentor does is support both the mentor and the mentee in an informal capacity. And how does that work? It works through the transition into the formal role from that G-mentor to formal mentor, that shared responsibility, work-based collegiality, supervision of students, and the assessment and judgment. It also means that the formal mentor could then rely on that collegial mentor with regards to assessment and judgment of any student in practice. So it's not just one individual assessing the student, there's more than one person assessing the student. That I'm aware from a SSSA perspective in 2018 NMC, they started looking at having more people being involved in the assessment of students in practice. And this shares some similarities with that, with regards to the formal mentor still having someone else to discuss as part of their assessment of the student in practice. I think that's quite important. So looking at some of the findings here. So when we start looking at one-to-one mentor, so when someone shares their knowledge, skills, so it's the traditional mentoring relationship that we had in Gibraltar, was very much a one-to-one mentoring relationship. And we're shifting that across. Now, there's also team mentoring and peer mentoring, which again shares some similarities to collegial mentor, but from a team mentor perspective or group mentoring perspective, it's when they have quite a few people working towards the same learning goals and work towards that development. So together, individuals make up the team and articulate mutual learning goals, which is again quite important from this perspective. So peer mentoring is peer-to-peer working together, whilst from my perspective, we start looking at formal relationships from a collegial perspective. The formal relationship is between the mentor and mentee. So that light blue and the orange, that's a formal relationship, which is mentor-mentee. Now, the collegial mentoring is the individuals that will then work with the student and with the registered mentor or qualified registered nurse as a qualified mentor. So it's that reciprocal relationship between formal and informal mentors within the workplace, and how they provide support and guidance and encouragement to each other, and how that goes hand in hand, really. So the primary function of the collegial mentoring or G-mentor is a collegial support to the formal mentor, and that becomes quite important. So instead of having the support from higher up or from practice education facilitators, from ward managers, the collegial support comes from those people working on the wards. And for us in Gibraltar, it could be anything from a nursing assistant to an enrolled nurse to a registered nurse. So it's looking at that, those echelons within nursing. And also the G mentoring process itself empowers junior staff to invite them for that role of mentor. So, for example, any newly qualified nurse could be that collegial mentor to a formal mentor, and that newly qualified nurse will be able then to learn the ropes and be able to then develop their skills going forward. So, why the importance of all of this? So, or the importance of collegial mentoring? It's an informal relationship between two or more professionals in the workplace. So it's not formal. And why is it not formal? If you formalize something, then it becomes something that has to be done. But actually, if you're the mentor, your mentor-mentee relationship, that informal relationship that the mentor decides generally is a professional that they trust and they can relate to, as opposed to formalizing it and having someone who they may not get along with, or they may not have the same train of thought as they do. So that's why it has to be informal. So there are no formal goals in this relationship. The goals are set between mentor and mentee. So therefore, this is more an informal element from that collegial perspective. So no formal meetings as part of the relationship. Again, the formal meeting occur between the mentor and mentee. Now, the collegial mentor could be part of that formal meetings if the mentor wants that support. And that's something that's quite important. So formally, there's no meeting or meetings as part of the relationship, but there will be discussions to be had. From that, collegial mentoring is non-hierarchical. Why? Because they're both registered nurses or registered practitioners in experiencing that relationship. So there's less going on. It also allows for reciprocity of ideas, where both parties share opportunity and experiences with the mentee to develop that mentee in practice, all the time supporting the mentor. It's based on mutual respect as professionals. It's based on work-based learning, so learning on the ropes on the job for those informal relationships. Mutuality, so sharing of those relationships. At times, it is unstructured, so ad hoc, as and when required. So if the mentor relationship is going fine and the judgment and your assessment of the student is not an issue, for many occasions, there may be someone else that they bring in. So that's the ad hoc, as and when required. And it's to support the assessment, to support the mentee in practice. So from a collegial mentoring perspective, I know there's other modules, for example, the CLIP in the UK from coaching, and so is the practice learning at Northampton plan, which is based on coaching. I'm a very firm believer that mentorship is still the way forward in regards to nurse education, especially in Gibraltar. And I'm aware that a lot of European countries are actually looking at mentoring a lot more as opposed to coaching. What's in the UK, they moved away from mentoring and more into coaching. A lot of European countries are going more into mentoring. So it's quite an interesting discussion to be had between those anyway. So the definition that I came up with regards to collegial mentoring was the reciprocal relationship between the formal and informal mentor within the workplace. Again, that informal mentor could be anyone as long as they're working within that community of practice. And I think it was mentioned before about Levan Benger's community of practice. The PhD in itself is the elements of community of practice coming through the whole PhD. And that was a discussion that I had as part of this chapter, which I'm not going to dive much into today. But it's where they work informally with the purpose of jointly providing support, guidance, encouragement, and facilitating the acquisition of new skills and or knowledge to a mentee. With the primary function of G mentoring is a collegial support to the formal mentor. And again, that collegialness is so important because the mentors themselves in practice will develop teams of individuals where they can actually work very closely with and be beneficial for student learning. G mentoring is a collegial mentoring process in the workplace through empowerment of junior staff, involving them to participate as informal mentors. There's also discussions about involving student nurses in as part of year 3. Some universities do a mentorship or equivalent module in year 3 as part of the student preparation for practice or newly qualified nurses. I think through a part of preceptorship in the GHE context, these newly qualified nurses should be collegial mentors to the student nurses. So keeping that loop early on. And that's it from me. So thank you. And any questions?
Thank you very much, James. That was an excellent presentation. We do have time for one or two questions. If anyone wants to put that into the Q&A section of Zoom. Otherwise, if anyone wants to raise their hand, they are welcome to and to ask the question personally. Does anyone have any questions?
How long did it take to do PhD?
3 weeks.
Actually, I've got a question for you. So this G mentoring approach, do you think it's
Yeah.
transferable towards other fields and disciplines as well, that are not necessarily the formalized mentorship paradigm that you have with nurses? Do you think there's something that could be adopted and transferred?
It could, absolutely. I do a lot of work with teachers as well. I actually prepare teachers and do a module with the teachers here in Gibraltar locally. And one of the things I spoke about, that collegiality, and how a lot of teachers, even though they got a classroom on their own, how they can work collegially with other individuals as part of that. So yeah, it's absolutely transferable. Absolutely. And obviously, I saw a comment being made that in the NMC in the UK look at practice supervisors and practice assessors. Absolutely right. As part of the triple SA, they do practice assessors, practice supervisors. Traditionally, previous to that, the NMC would look at mentors, and that is something that we did in Gibraltar. We didn't adopt the triple SA to go into practice assessor, practice supervisor, which I think is quite a junior role. And I think looking at my role and with colleagues in the UK, there are issues with the practice supervisor and practice assessor and educational assessor already being highlighted in the literature. So it doesn't mean that it's a solution to clinical practice, what the NMC have done recently from 2018.
Excellent. Thank you, James. If no one else has any questions, then I think I'll just thank James for his time and for delivering such a great presentation, and also tell you that we are now going to have a lunch break. So it's going to be for an hour from 12:30 till 1:30. So I hope to see you all back there here at 1:30 GMT +2 Gibraltar time. Thanks again.
Thank you.
Thank you.
Welcome back, everyone, to the International Conference for Healthcare Professionals 2024. our inaugural conference. And it is my great pleasure to introduce our next speaker, Professor Neil Cook, who is a professor of nursing and head of school at the School of Nursing and Paramedic Science at Ulster University. Neil is also a principal fellow of the Higher Education Academy. He has led the School of Athena Swan team for the school to achieving their silver award. Neil is also president of the European Association of Neuroscience Nurses and an executive board member of the British Association of Neuroscience Nurses. A key component of Neil's work is in-person centered nursing, particularly in its application to both practice and education. Neil has a background in neurosciences, anatomy, physiology, and pathophysiology. He has worked in the fields of neurosciences and critical care since registering as a nurse, becoming a specialist practitioner, and subsequently moving into education and research. Neil has published clinical, research, and education papers in the fields of person-centeredness, education, and neurosciences, and remains very active in these endeavors. He remains clinically active in neurosciences and is a registered nurse within the Nursery and Midwifery Council UK. The title of his talk is Developing Person-Centered Caring Attributes in Practice. And with that, I will invite you, Neil, to share your slides and hand the mic over to you.
Thank you very much for that introduction. I'll just get this up on screen. Hopefully you can see that okay, yeah?
Yes, yes, we can see.
Thank you.
Thank you.
So thank you for that introduction. So I'm going to talk about person-centeredness and the curriculum, and particularly with a focus on practice learning as I go through these slides. Now, I could probably talk for weeks on this, so I'll do my very best to keep the time. But some of the slides that I have in there will be really for people to go back to if they want to get some more detail. And I won't go through every slide, but I just want people to have the detail. So really want to start talking about the contemporary challenges of achieving person-centered practice from an education point of view right through to flourishing practitioners. And that's really, I suppose, quite a common goal for all of us when we think about where we want our profession to be. I want to talk a little bit around the philosophical considerations and the models and bring it all really from a project right through to a universal curricular model for person-centered curriculums that we've developed in partnership with 5 other universities as part of an Erasmus Plus grant. So I think this background will probably be familiar to everybody who's on the call today, but humanizing healthcare is obviously a strategic focus globally, particularly since the pandemic, where there was a little bit of a shift back to task orientation as part of that, I suppose, survival of that pandemic. But there is very much a need for person-centered approaches to practice with people being at the core of healthcare delivery. And when we talk about people, we don't just mean the people in our care and families, we mean actually everybody that we work with as well. And so person-centeredness extends beyond the patient and the family. So really, when we think about that, educating healthcare professionals is really fundamental. If we want to create person-centered practitioners, we need to start with education. We need to start with values, beliefs, and then make sure that those translate into behaviours. However, we do know that very few curricula embrace person-centeredness as its underpinning philosophy, and very few curricula take a whole systems approach. And that has been, I suppose, really evident throughout the literature when we look at how we develop caring attributes in particular and person-centeredness. And there are a number of papers, if you just look a little bit at the timeline there, going back, really back to 1999 to Roger Watson's really important work with the Caring Dimensions Inventory, right through, we have been able to demonstrate consistently that student nurses lose caring attributes as they go through pre-registration programs. And this is obviously a significant concern. And we need to understand what is it about their journey through nurse education that results in them losing caring attributes that they may have actually come in with. And so at the point of the study that I had undertaken, there was no studies that have been done to demonstrate, first of all, that we can develop caring attributes or that we can fully understand what it is that's caused students to lose it. There's elements in a number of those papers, but what was the fundamental issue? So with that in mind, I undertook a study to develop caring attributes and person-centeredness through a person-centered curriculum, and to track a cohort of students from their first year right through to their third year. And the tools used were the Caring Dimensions Inventory, the CDI 35, the Portfolios on Nursing Education Questionnaire, and focus groups. And it was a combination of those factors to try and understand the students' journey, particularly through practice learning, but actually the results that came out really were curricular wide, to look at how they developed their caring attributes and what it was that they needed to support them in developing those caring attributes, particularly in the practice learning components of programs, because this is where we would expect to see those caring attributes lived out. So preceding this study, we've done quite a bit of work with mentors, as they were known then, and with students to develop a portfolio, not just as a mode of assessment, but as a framework for learning through practice. And so this study aligned really with a new curriculum that was underpinned by the person-centered nursing framework as its curriculum model and this portfolio. So the goal was to track these students' developments and their experiences at each year through an action research project. And as part of doing that, we had a stakeholder group that included people from practice, so practice education teams, students, academics, and also people from policy at the Department of Health, so that we could fully understand from a systems-wide approach what it is that we needed for these students to develop as caring professionals towards being person-centered practitioners. And as part of that, when the data came in from all three sets of data each year, we undertook critical creative hermeneutic analysis as a group analysis of the data to understand what the enablers and inhibitors were for students developing in practice across the curriculum, and develop recommendations from each set of data that would be rolled out regionally to help support those students develop. And this actually turned out to be very, very successful. So we had a number of findings. So from that process, with 65 different actions over the 3 years that were collectively developed and implemented in partnership by practice, by the university, by stakeholders across that group, as I mentioned. And what we found was that the things that were really important were support. So support came out as the primary issue that students have, and a lot of literature since then continues to show this. And that really what they valued was dialogue, that was authentic dialogue with them. They valued where people give them time and practice rather than things being rushed to look at how they were developing. That sense of being valued in terms of the contribution to practice, even as a student. An authentic engagement with them, supportive feedback, and direction for future learning. What also came out was a need to focus on the process of learning over the product of learning. So we learned from previous curriculums that students really were so focused on getting a portfolio completed that became the focus of their learning rather than the process of learning against proficiencies and to be practitioners. And so this portfolio took a different approach where the process was probably more important than the product. And that's because it wasn't just what's your evidence, it was a framework for them to learn. And also that the portfolio gave them access to learning opportunities, and it also created the pathway for them to get those. For example, they didn't have to negotiate so many things. These things were laid out as things that needed to be done, and those pathways and packages of evidence that could support them to do that, and that gave them access to those learning opportunities across the board. And the other, I suppose, really important factor was this was the first curriculum that we've run at Ulster where students actually valued critical reflection and found it as very, very important, but it had to be an authentic critical reflection. And one of the things that we did was we removed any need to reference it. We removed any, I suppose, framework that made it an academic piece of work, and we very much made it about it being a practice-based, authentic critical reflection. Because what we found beforehand is when you started to move it into any kind of academic parameter, students looked for references, and then they used the references as a framework to find something in practice to reflect on, rather than reflecting authentically on things that came up in practice and then aligning that in any way to any evidence or code of practice. So we found that when we addressed all of these factors across these 65 actions, we started to see a progressive improvement in caring attributes in particular, and more resilient, informed, and developed students. And what we found was that caring attributes were sustained and developed further by the point of registration. And this was the first study that we know of in terms of what's been published to be actually able to demonstrate this. And they really found the students to really self-actualize in terms of their concepts of caring, person-centeredness, and resilience, but not resilience in terms of the ability to tolerate stressful practice, but be able to find solutions, to challenge practice, and to improve practice. And you can see one of the papers published there below. So we felt we couldn't really stop at that point. We found that degree education for nurses has been long criticised. The too posh to wash and all of that. And you can see across the 3 years of the programme, the key things that students ranked as the most important priorities for them were, and these very much stayed within the same top 5, was listening to a person, getting to know them, assisting the person with activities of living, being involved in their care, providing privacy, and advocating for them through reporting. So contrary to all of that evidence, this really demonstrated how these components remained at the top, but actually some of them moved up as stronger as students progressed through. And this was really important in terms of what we wanted this curriculum to do. So all of the findings really were brought together into a framework. And it could take me an hour to go through the framework in detail, but you can see that this framework for practice learning picks up all of the data that came through, right from recognizing that there are things that are macro context issues, such as having a curriculum that's aligned with the person-centered practice framework, having alignment between health and social care policy and the pre-registration education standards, because we found they weren't always aligned. We had, a set of standards expecting X, Y, and Z of students, but we have policies and practice that did not permit that, or were moving in a different way. We also found that prerequisites were core issues, that clarity of beliefs and values that I mentioned earlier on, having authentic collaboration in the design of programs right through to review, and a commitment to dialogic engagement with students. We could see from the data that scaffolding the curriculum was really, really important, and that practice learning experiences needed to be transformational rather than just procedural. And there was a number of factors you can see there around that. And ultimately, those factors would lead to person-centered practitioners. And that meant that we really needed to consider culture in quite a strong sense, and that essential culture would enable transformative learning for human flourishing if we got all of those elements right. Now, this work then led, I suppose, to a next set of work for us. And it made us start to think of the context of education around person-centered practice, and linking in with the people who were key in developing those frameworks. So that's largely Professor Tanya McCants and Professor Brendan McCormick, who have led globally on work around person-centered practice. But it led us to believe that really the traditional approaches to curriculum development haven't really been doing their job, because if they're disconnected from practice frameworks, and that we needed to have curriculums that were arguably much more agile, and then it needed to be founded in the principles of co-construction, relationalism, pragmatism, and being transformative. And then we needed to see those philosophies being lived out entirely across that curriculum. And we asked ourselves, really, do any curriculum models represent that? And we felt that, I suppose, through an international community practice for person-centeredness, when we examined this, we felt actually that this isn't present, and we needed to do some work on that. So we worked across 6 universities, across 5 countries. It's now broader than that, to look at developing a universal curriculum framework for person-centered practice. So we started by looking at the 2 frameworks that hopefully most of you have seen before. The person-centered practice framework is the one on the right, the one in the the yellows and greens, and the person-centered nursing framework. And I suppose if I was to distinguish between these two frameworks, the nursing framework looks at the unique contribution of nursing, and the practice framework is wider than that, and it looks at person-centered practice from an interprofessional context, but it also includes that macro context where we recognize that there are influential things in leadership, policy, strategy, etc., that influence how we work. But we felt that these two frameworks, while they were very good at picking up around practice elements, what was translating these into educational curricula, and that we needed to do some further work there across the curriculum. So as I said, our goal was this universal curricular framework, but it needed to be a framework that works synergistically with other curricular frameworks if it was going to be successful, and be able to be adaptable and agile to work alongside curricular structures that exist in most universities, and recognizing that education doesn't just happen in the university, but very much happens in practice as well, and so it needs to be adaptable to that setting as well. And we sat back and we looked at how we operationalize person-centeredness in curricula, and we knew that we worked from the theoretical frameworks and philosophies, but we needed to have an operational group that worked around curriculum development, but also about being strategic and political and leading in that space, and also bringing in person-centered research to inform what we were doing, so that we're not just basing it on principles, but actually working from the evidence. And there's quite a body of evidence now around person-centered practice in education. But we needed to consider how we bring people in to be collaborative and authentic in that space. So we needed to collaborate right across the sector. Sorry, that jumped on me. And to use involvement with our strategic partners in order to achieve that. And we worked through a whole Erasmus project, and we came up with our curricular framework, which you see on the screen. Now, again, it could take me another hour to talk you through this in any detail, but you'll see that there are, I suppose, the 7S framework being used. This is McKinsey's 7S framework, which you see along the right-hand side. But all of those 7S's coming together with the philosophical principles of pragmatism, co-construction, being transformative and being relational. And when we talk about those principles, what do we really mean? I think a lot of people on the call probably recognize the need for co-construction, that we can't deliver curricula and build curricula in isolation in universities. We need to do this, that it's a socially active, embedded process that involves all stakeholders, and that it needs to be reflective of all of those people if it's to be delivered realistically. But that needs us to be relational, and that means that we need to engage with each other, but engage with the socio-cultural context that curricula operate in. So they don't just operate nicely and neatly in a university. They are very much embedded with what's happening in the social world and what impacts on students. Pragmatism, most people will know about, but that we need to, I suppose, really consider about how we engage with each other, how we underpin the values of the programme, with shared human practices, and deal with problem solving and action as opposed to describing and thinking, as an underpinning philosophy of curricula. And then finally, about being transformative, that we know that we need people to be able to go through a curricula that transforms and develops them, very much aligned with philosophies of Paulo Freire and Jacques Mezereau around education. And that requires us to have high standards of ethical leadership and service to others, which is very much aligned with the philosophies and principles of nurse education. So I've mentioned the person-centered curricula being underpinned by the McKinsey 7S framework, and we use the methodology of Kinsey to do it. And the 7S's are listed there, and you can see, I suppose, some descriptions of them. We've talked about the hard S's being strategy, structure, and systems, and the soft elements being skills, style, and staff, and then shared values kind of sits in the middle. So shared values being in the middle is really important, because unless you establish the values and then align the behaviors of what we do, we can't live those values out. So that's, I suppose, a fundamental starting point with us when we look at curricula. But we have to think about the strategic, structural, and system elements of it. What's the unique selling point of the program? What makes it unique and attractive in terms of being strategic? But looking at how the structure of that curriculum interconnects with the values and beliefs that we have around person-centeredness, and how do we align that with the systems that we're using in universities and in practice around teaching and learning and assessment methods that, again, aligns up with the shared values of person-centeredness, but exists within the systems that we have. And do we have the people to deliver this, who have the understanding of those philosophical principles, but also the person-centered frameworks? And do they have the skills? Because it's not about a didactic approach to education. It's very much about a transformative approach to education. And that largely means that we need to use facilitation skills more than anything else to be able to deliver it in a very different style than traditional curricula would deliver on. And I'm going to just give you an example of some of these. But before I do that, there are three, I suppose, fundamental papers that go through this. They're all open access through the International Practice Development Journal. And I would really recommend anybody who's interested in delivering a person-centered curricula to have a look at these articles, because they start with summarizing where we're at in education, but then they talk through the models in detail. So I've left in slides in a number of places here for you to be able to go back to them. But for example, on strategy, it's, we need to understand what's our explicit and intentional focus on developing person-centered nurses, for example. We need to understand clearly what person-centeredness is and isn't, and there is quite a mismatch at times where people think patient-centeredness is what person-centeredness is. So we need to make sure that there's a really attention towards the detail of that. Can we develop a program that can adapt to changing healthcare contexts? And is it developed through authentic co-design with stakeholders? And from a strategic point of view, you must embed person-centeredness throughout every level of curriculum design and delivery if you're going to strategically deliver on the curriculum. I'll give you another example or two. So for example, if I go to shared values, which I think is probably really core, it's a core element of the person-centered nursing framework and the person-centered practice framework. But it's about making these core values of the school or the faculty explicit with an intentional focus on working with persons. And that means, thinking about people in the wider context. So things that you could consider are co-creating a vision that will shape the program's development. It's about making the values really explicit, about opening and encouraging the conversation around the stated values of the team delivering the program, really examining those to make sure we're all on the same place. But if we are in the same place, how are these values influencing the way the curriculum will be delivered? And that quite a lot of the time we have to look at that aligned with behaviours, what we say we do and what we actually do, and the experience of students and other stakeholders in that process. And do these values match up with those of the stakeholders? So quite a bit of what we do starts with shared values and getting that right in order to get the rest of curriculum design right. I'm going to leave these other slides and skip on, but they're obviously there to help you with some questions. But there's some other considerations, I suppose, that we need to always consider. And that starts with, thinking about what can you achieve in your timeline. It's great to have this end goal of really strong person-centered curricula to get person-centered practitioners, but it takes time to get there. So we first underpinned our first curricula with the person-centered practice frameworks in 2010. So we're now 12 years on. Would I say our curricula are perfect? Absolutely not. It's still a journey. We've just recently put through our specialist community public health nursing and our specialist practice programs at postgraduate diploma level using this universal curriculum framework with great success, and it'll be great to see how they roll out. So it's the first time we've adopted this curricular framework alongside the practice frameworks. So it'll be great to see how those are implemented, but it was certainly commended by the panel in terms of being explicit right throughout and following the 7S framework to do so. So it is a journey, and you might not achieve everything you want in the beginning, and you might not achieve it 12 years down the line. So you still have to work towards that. And another key, I suppose, consideration is that curriculum is not the document. The curriculum is everything that surrounds that curriculum. So emancipating practice, really, to do this is not easy. It's often political. We have to be political in how we move it forward, and it's not, and it has to be unsettling. If you're not unsettling things, what are you really changing? How are you really shifting and move things forward? And part of that is looking at the culture and the leadership, and then being able to identify what are the things that enable us and things that inhibit us from moving forward in this direction as part of working through those 7 S's. And really that takes me to the end, and just to say thank you for listening. I'm obviously very happy to take any questions or make any clarifications needed.
Thank you so much, Neil. That was really, really interesting. So I'd like to open the floor for any questions. Please feel free to put in the Q&A, or if you would like, you can also have a go at raising your hand and ask personally. We have time for about 1 question. Well, I actually have a question for you. I think it's really interesting, the whole idea of person-centered versus patient-centered. Sort of, I think with the patient-centered, it's about the fact that it's functionally appropriate as opposed to caring as much about the sort of quality of life sort of thing, isn't it? So is this transferable to other healthcare professions as well, like medical doctors or paramedics and this sort of thing?
So the universal curricular framework that this person-centered curriculum framework is multi-professional, and it was developed across professions. So we had lots of allied health professions involved, medics involved, etc. And that's, I suppose, in recognition and alignment with the person-centered practice framework, which is multi-professional as well. And you see it being used, particularly in Ulster University. It's been used in our School of Health Sciences alongside their curriculum now as well. So it's extended, while its origins were in nursing, it's certainly extended beyond that. And in our school, we also use it for our paramedic practice curriculum. And it's extremely well embraced there as well.
Thank you. Thank you so much, Neil. I know you have some messages in the chat. One person has said the timing for us here in Brighton is absolutely perfect. Neil, if it is okay with you, I'd very much like to pass your details and your presentation to my course and nursing lead colleagues.
Absolutely. Very keen to support anybody in their endeavours with it. And we have an international community of practice, which is very active, that people might find supportive as well.
Excellent. Thank you so much, Neil. That was really interesting. So I think now we can move on to our next speaker, Professor Lynn Karstad, who retired in 2023 after a career that spanned more than 40 years and embraced both nursing practice and university education globally. Having held senior positions in both the UK and Australia, her final role was that of Vice Chancellor at Fiji National University. As a registered nurse and a licensed teacher, her current research interests are diverse and include aspects of both disciplines. With PhD students in Australia and Southeast Asia, she continues to publish and be actively involved in contemporary research. She holds honorary professorial roles at both Newcastle University and New South Wales and Charles Darwin University in the Northern Territory. Her focus is now upon the nurturing and support of the next generation of leaders, both within healthcare education and university life more generally. The title of her talk is How Many Hours Are Enough? An enduring challenge for the nursing community across the globe. And with that, Professor Karstad, I'll leave it to you.
Thank you very much, Leon. Can you hear me?
Indeed, yes.
Yes, yes.
You can hear me, you can see me, and I'm sharing my presentation. So I've got the first 3 things right. So hello and good afternoon. I'm very happy to be here and to be a part of this inaugural conference. In the company of such other wonderful speakers. I've enjoyed every talk that I've heard today. And I think that in a way, they all apply to what I'm going to say. So I'm very happy to be here toward the end of the day because I've had the benefit of listening to those that have gone before me. And actually, I think in some ways, this presentation is more of the same, but it's very different. So this presentation is different in that I'm not really at this point presenting any research findings. At this point, I'm here to make you think, whoever or wherever you are. So, on to my first real slide. My name is Professor Lynn Karstadt, and first of all, I'd like to contextualise just who I am. And this first slide, I think, does that in quite a succinct way. So I have quite a long history. I have many years as an academic in the UK, and for the last decade, I've been in Australia and then in Fiji. But in 2012, I came to the end of a 5-year period when I wrote a monthly column in the British Journal of Nursing. It was a comment column. It wasn't a research-based column. It was a comment column, and it was down to me to choose something that was challenging the nursing profession at that time, to make comment on it and to stimulate discussion and debate. And that's really what I'm trying to do today. At the end of that 5-year period, having done it monthly, I had 60 columns that I had written, and each column was 1,000 words. So I put those 60,000 words into Wordle. Now, for those of you who don't know what Wordle is, I don't think it's used very much anymore. It's a computer program where you put in all the words that you've used. It takes out all the incidental words like is and the and at, and it takes the more significant words and it looks for the number of times that you've used each word. And once it's got the number of times you use each word, it creates a picture of the words that you've used, with the words that you've used most often being the biggest and the words that you've used least often being the smallest. So I actually think that if you go back to 2012, this was my ontology. This was my view of the world. So when I came to today's presentation, I decided to return to a question that has bugged me for many, many years. So for many years, I've been thinking alone and with others, how many hours are enough? An enduring challenge for the nursing community across the globe. And at this point, why I think I'm able to answer that challenge. Now, it's a very interesting question, and it's something that has consumed me over the years. I have led a couple of research groups who have looked at this from a global perspective. And that culminated in 2015, 2016 in our presenting at the Nurse Education Today conference. And both times we presented as a group. The first time it was a group of Australian and British nurses, and the second time it was slightly wider than that. And we looked at lived experiences and we looked at the statistics and we commented and we posed questions. But I've come back to it today, not because I have any new data, because actually I don't. But I'm going to today explore whether it's still an issue and whether this question still needs answers. So each time I come back to the question, my perspective has slightly changed. I'm now retired, and initially I concluded that after a long and varied career, I was in a great position to give some objective observation. However, any good qualitative researcher knows that we all bring our own view of the world, our own perspective. Some people call that our ontology. And this presentation is therefore from my ontology, from my view of the world. And although my perspective is unique, it really isn't objective. I bring my own bias. So I suppose one thing I ought to say is that our perspective continues to iterate as the years pass. So our ontology is very fluid and it changes according to our experiences. And mine is no different. So I'd like to show you another word picture. So in 2013, I moved to Australia. Until that point, I'd worked as a head of nursing in the UK and a dean of health and human sciences in the UK. When I moved to Australia, I moved to a slightly more global role. I moved, first of all, to lead a faculty that was just concerned with sciences, not nursing sciences, not even health sciences, all sciences. It included engineering, it included astronomy. It was a very diverse, super faculty. So my perspective changed. I did, however, retain responsibility for nursing and health within that faculty. So I didn't lose my nursing perspective, but it was slightly modified. If you look at this word picture shows you what my perspective was in 2019. In 2019, I was asked to do a talk on my ontology and how my view of the world had changed over the years. And in order to illustrate what I was saying, I put all the documents that I had dealt with in a 4-week period into Wordle. It took me a while to find the program because by then it was becoming quite dated, but I put them all in there. And as you can see, the words that came out that were my focus were very, very different. I had moved to a more global, a more managerial, a more administrative focus. So back to my question. How many hours are enough? I think I went forward too there. How many hours are enough? It is an enduring challenge for the whole of the nursing community across the globe. And it's something that we all bring a perspective to. And what I want you to think about this afternoon is what is your experience and what is your perspective. So a very good question is, why revisit this challenge now? Well, first of all, I'm going to look at it from a UK perspective. At the moment, we've got a huge opportunity owing to Brexit. Brexit meant, of course, that we in the UK left the European community, the EU. And for many years, the EU directives had been absolutely central to a nursing student's experience in the UK. Now that Brexit has taken place, is this an opportunity? Should we take this opportunity to actually think about whether the EU directives are still appropriate and whether the EU directives are beneficial, whether they're a driver or whether, in fact, at this moment in time, they are an inhibitor? Another reason to revisit this challenge now is that last year, the NHS England published the NHS Long-Term Workforce Plan. And as part of that plan, they promised 24,000 more nursing and midwifery training places by the year 2031. Now, that was more than an 80% increase in some branches. So it was around 80% in the adult branch, 100% in the mental health branch. Hang on, don't quite know what I did there. Go back, sorry. And a large percentage of students more in learning disabilities. I think the only branch of UK nursing that won't be hugely increased will be the child branch. But 24,000 more nursing and midwifery training places mean that we will have 24,000 more students in practice by 2031. And you have to ask if we can cope with that. We've heard a lot today about practice learning. I was particularly taken with the sustainability presentation and how that could apply to practice learning. And I made a little note, could we calculate clinical practice hours in a more sustainable way? Can less really be more? And I think that what Heather was talking about, I think less really could be more, because students want to have, to take Neil's words, a really authentic engagement. And if we were to almost double the number of nurses who are being educated in our systems, would we really be able to give them all an authentic experience? Students are already reporting stress and a lack of support in placement. How much worse could that get It could certainly get a lot worse if each mentor had to take twice as many students. Again, this is totally in a UK context. We know in a UK context that placement hours are deterring prospective students in the UK. If I'm a student and I'm thinking of doing nursing, I have to do 2,300 hours of practice. That's a lot of practice. It means that you don't really get student holidays. It means that you don't get the same sort of experience. If I choose to do physiotherapy, radiography, or paramedic science, I have to do 1,000 hours of practice and sometimes even less. So is that significant in people's choices? Finally, revisiting this challenge now, it's a good time. We've got a new government. We've got a new government who really want to put their stamp on healthcare. The NHS long-term workforce plan was done under the guidance of the last government and the civil service who work for them. So maybe this government are in a position where they really want to embrace something that they can put their name to. So let's move to an international perspective. The next question for me is it hours that we should be measuring? Well, Sam told us that all healthcare students have similar problems. And we've just mentioned the fact that students of different professions are expected to do different numbers of hours, but they all experience the same sorts of problems. When it comes to nursing, we also have to think about paradigms of nursing. We maintained the 50% of practice hours when we embraced Project 2000. And some people think that was really to do with keeping the general public happy. Somebody else has mentioned today, I think it was Neil, the too posh to wash, the idea that an all-graduate profession, nurses who were trained in seats of higher education, wouldn't have the same caring attributes. Again, it really comes back to everything that Neil talked about. But there are many paradigms of nursing. What is a nurse? Is a nurse a doer, somebody who practices using their hands? Or is a nurse a thinker, somebody who is a problem solver and somebody who can lead and motivate others? Or is a nurse a carer? I go back to my own PhD, and what I think I concluded at the end of a very long study and collecting lots and lots of data was that, in fact, the nursing paradigm that I would favour would be a direct combination of all three. If you have a Venn diagram, it's that intersection of the three circles that give you that professional nurse. So, paradigms of nursing. The next question we have to ask is the lens that we look at this through global? Or is it a UK lens? Or is it something that's different from both of those things? And I've put in brackets Gibraltar. I've had a little bit to do with the School of Nursing in Gibraltar over the last year. And talking to the academics there, I think I've come to understand that they don't really fit into the UK model and they don't really fit into the truly international model. They're kind of an interim, they're somewhere in the middle. Is this a chance for Gibraltar and the likes of Gibraltar to look at practice in a slightly different way, through a slightly different lens? Is the nursing workforce international? Is the nursing workforce truly international? Nurses in, nurses out. All those years ago, and it is many years ago, when I was considering my own career trajectory, one of the things that influenced me to do nursing rather than some other healthcare type profession was the fact that nurses, particularly British nurses, are accepted and welcomed across the globe. It's a passport. It's a passport to practice wherever you want to go. But is it truly an international qualification? Are we able to compare nurses from the UK with nurses from Australia, with nurses from the Philippines, with nurses from the US, etc., etc., etc. We know that in both the UK and in Australia, almost 50% of the nurses on an annual basis who are new registrants come from overseas. That's a lot of nurses that are coming in and out. And there's no doubt that the NHS new workforce plan probably wants to reduce that slightly. And that's why they want to train more nurses. So what's the current situation? Well, actually, the current situation is there's very little global consensus. And I've got a few statistics here from the UK, from Australia, from the Philippines, and from the USA. Now, these are the hours of practice that nurses in those places are expected to do. And the first thing I hear you say, I can almost hear a sharp intake of breath, is that, well, it's not 1,700 in the UK, it's 2,300. Everybody knows that. But these figures are exclusive of the allowed simulation. So in the UK, you've got 1,700 hours that must be in clinical practice. In Australia, you've got 800 hours that must be in clinical practice. In the Philippines, you've got 1,087 hours that must be in clinical practice. And in the USA, it's slightly different. It's less than 434. How specific is that? Hours in an actual ward or clinical environment. And if I put up the next slide, you can see that these numbers truly do not include the allowed simulation hours. And we heard a lot this morning from Guillaume about the allowed simulation hours, about how we delude our students, how we deceive our students, but how that works in their best interests to give them a good all-round practice education. So once you add in the allowed 600 hours in the UK, it gives you 2,300 hours of practice. Now, in some places, it is 2,300 hours on the wards, but in most places these days, they do use the 600 allowed simulation hours. In Australia, where I've had a lot of experience, simulation isn't included in the hours that ANMAC count. ANMAC only count the hours that students spend in clinical practice. So any simulation hours are over and above that. In the Philippines, you can see here that students can do up to 800 hours in simulation. And in the USA, it's expected that around 50% would be in simulation. So students in the USA, generally speaking, would have about, so it seems a very specific figure, but 868 hours of clinical experience. So that's corroborated. It's corroborated well in the literature. If you go back to my abstract, I haven't been as good as Neil was and put all my references on the individual slides, but I'm sure the abstract is available for everybody to look at. And there's a reference list within the abstract. The most recent article that I used was one by Garrow et al., which was in the BJN in 2022. And that quoted these figures. I also put in the links to the particular national boards, the NMC and ANMAC, to show, in fact, what they state needs to be done as part of their regulations. So, no current consensus, and we now need to be moving forward. So, what questions should we be asking? Is it just quantity? What about quality? So, in fact, the quantity of practice is one thing, the quality of practice is another. And if we look at that in the context of the NHS workforce plan and the fact that the number of students is going to increase so dramatically, we have to accept that the number of students who will be out in our clinical areas will make a huge difference in what's going on in the wards. So I kind of return to that sustainability. Could we calculate clinical practice hours in a more sustainable way so that every hour counts? I used to have a boss back in my early days in nurse education who would say, We don't want hour one, day one, week one, month one to be repeated throughout a nurse or midwife's trajectory through nurse education. Every day, every hour should build on the previous hour, so nurses become more and more skilled. But the more nurses that we have on our wards, it's more likely to be about counting hours rather than the quality of those hours. It's about student experience. So from whose perspective? There are lots of perspectives when we start to look at student experience. We know that there are many academics and university administrators who spend hours and hours creating experiences for students. Now, we only create experiences that we think will be useful, but there's no doubt that some experiences are more authentic than others. It's time in practice that should be, to use Neil's word, authentic engagement. So the student experience is indeed very, very important. So could we reduce the number of hours that students do? Could we? I think we probably could, to come up with some level of clinical practice that would be more comparable across the world. What's the place of simulation? Guillaume gave us a very kind of lucid talk this morning about the good deception that we use with students to make them believe that they are truly being engaged in proper clinical practice. I thought that was really, really useful. And should we be increasing simulation even further than it is already increased? Or should we be capping the amount of simulation? All good questions. Should we be thinking again about skill mix? So has enough thought gone into the skill mix within our ward and clinical areas? And we're not just talking about the hospital now, of course, we are talking about the wider community. During Louisa's presentation and in James's presentation, both of them mentioned the role of the wider healthcare team. They both mentioned specifically healthcare assistants and how healthcare assistants can encourage students to widen their knowledge, can encourage students to widen their clinical skills experience. But the healthcare team is very wide. And the new assessment regulations came in 2018 in the UK, allow others rather than just nurses to be involved in mentoring with a small m, assessing student nurses. And do we have to take that even further? Do we have to talk about skill mix and how many nurses we actually need? And finally, are we ever going to have true international standards? If we are, how are we going to have true international standards? At the moment, we bring nurses into the UK, we bring nurses into Australia from all around the world, and we have to satisfy ourselves that they have the skills and competence of the home nurse, because we're going to put them into the NHS, we're going to put them into the Medicare system. We need for them to be competent. So we assess their competencies, but it's done very much on a skills basis. Is their problem solving also assessed? Is that standard across the world? These are all very interesting questions. So that's where I am today. This is your call to action. I want you to be proactive. I want you to talk about it. It's something that we are very, very busy in our professional lives. And it's something that we don't necessarily have the time or the energy to engage with. But it's actually all our responsibilities to be proactive, to talk about it, to decide where you stand and why. Do you think that nurses in the UK, do you think nurses elsewhere should be doing the equivalent of 2,300 hours of practice? Do you think if we did 1,000 hours of very meaningful practice that was much more closely monitored, that would be enough? Do you think it's somewhere in between the two? Do you think it's 1,200, 1,500, 1,700 hours? Do you think we should be counting hours at all? Do you think we should be counting clinical skills, competence, decision-making, abilities? What do you think? My talk is to say, lobby, 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 lobby. Talk to as many people who will listen. Talk to the nursing boards. Let them know what you think. Talk to government or your MP as appropriate. Get these questions raised. As an international community, nurses, we have a voice and we've got a responsibility to use that voice. So I'd love to hear what you think. If we're going to do more research, if we're going to collect more data to guide the government of the day, to guide the NMC, to guide ANMAC, what do we need to collect? In the research that I've done previously, we've collected data from nurse managers, from supervisors, from the students themselves. We've looked at it from many different perspectives, but whose perspective is authentic? Whose perspective is the most important? So I'd love to hear what you think. We have very limited time now. I think I've got about 4 minutes left. And I know that in forums like this, people are often quite shy to ask questions and share what they're thinking. People often want to be considered to go away and think about what they say before they say it. But please email me. Let's enter into a dialogue. I'd be very interested to hear your questions and your comments. So this is me. This is me with my multiple perspectives, the person who can't be objective because none of us can be objective. The email address that I've given you here is my email address at Charles Darwin University, where I'm an adjunct professor. I have good contacts there, and I think should we want to get into some sort of joint research, then we can start to mobilise the nursing profession. I know that you've got an international audience today, so well done to Leon, Louise and James for doing that. This may be a good springboard. Or maybe we've decided that we've talked about this question enough. The decision is yours. Thank you.
Thank you, Lynn. That was a really great presentation, food for thought, certainly. And I like the way how you alluded to all the previous speakers. I thought that was really, really great. We do actually have a question for you in the chat, which I'm going to read out now. The world of UK healthcare has recently been challenged by the current new health minister in a statement, the CQC is not fit for purpose. What are the implications for nursing?
That's a very good question. And I think we're going to have to wait to see how this plays out. I think one of the things that was said within that statement was the CQC aren't being selective enough in what they are auditing, and that where things are working well, they probably need to be audited less. And where things are failing, they need to be audited and monitored more. I think that the new Health Minister has a real responsibility now to move this forward, and we should wait and see how this pans out. The CQC, generally speaking, I suppose it's like any kind of audit body. We have the same in schools. They're always going to come under criticism. But in my opinion, it should be soft touch where things are going well. And where things are failing, you need to take more interest and be more interventionalist. But we do have a new minister, and that minister will want to make her mark. That minister will hope to be associated with moving things forward. And that's one of the reasons that I thought this would be a good presentation for today. Because if we're going to lobby, we may have keen ears listening. I hope that's good enough. I think it's something that it'd be interesting to see what's written over the next few weeks in relation to that CQC statement. I think it was quite inflammatory when it was made. So well done, whoever asked that question, because it's a very competent question.
Thank you, Lynn. We've actually got Louise who would like to ask you a question, and then I think we can close.
Well,
go on, Louise.
It was just really a thought. Because you said about what makes practice meaningful, and whether it's not about counting the number of hours, it's about making that practice meaningful. But how do we measure meaningful? And do we need to measure meaningful? And how can we as educators make sure that that practice is meaningful? I think that's probably a study within itself, isn't it?
I think that's probably where we need to go. I think Neil used some very good words, and some of the content of his presentation, I think, was absolutely blinding. In that he talked about, I wrote the words down. He talked about authentic engagement. And I wrote down time in practice. It's all got to be authentic engagement. Mm. And he also said the curriculum is not just the document. And I've written, neither is practice just the hours. Mm-hmm. So I think that you can actually spend 2,300 hours in practice and still come out and be totally incompetent. And another student could spend 800 hours in practice and come out and be blindingly good. So it's about measuring that, Louise. You're absolutely right. Again, Neil made some very good points about removing some of the academic framework off reflection to allow students to reflect and get to the heart of the matter in order to progress their learning. And maybe we should be doing more of that. Sam talked about having students who are in geographically remote areas being able to come together and reflect on their practice. So when I was a student nurse, we used to all live in the nursing home. I mean, it was 100 years ago. We'd live in the nursing home, and at the end of the shift, we would all pile back into one person's room. We'd all sit with a mug of tea, usually nothing stronger, a mug of tea, and we'd talk about what we had experienced that day. And we talk about what we've done well, what we've done badly, how we might do it differently next time, how we admired some of our seniors and betters, and how we criticised other of our seniors and betters. We now have to create that opportunity for students. And I think what Neil said about removing the academic framework to allow them to do that is a great thing. And if you look at what Sam talked about, and the opportunities that we've now got to do that virtually. So we all know that students are glued to their phones, they're glued to their computers. So if we can create groups where they can come together to reflect, is that authentic for the young people of today? Is that where we should be going? Rather than pulling them into the university and giving them a framework that we expect them to fix everything around. Because my experience would be with Neil's, as soon as you do that, they pick an experience that would fit into the framework. They don't pick an experience that they really want to explore because they can't see how the framework might apply.
Well, that's that virtual community of practice, isn't it?
But that virtual community of practice may well be a way forward. Yeah. Particularly where we have the huge groups. I mean, you know, what Sam's done has been absolutely breathtaking. And for rural and remote students in places like Australia, where many of the student nurses do all their lectures online and do all their practice in remote placements, and they probably only come together for a month a year for intensives. To actually be able to put them in those virtual communities of practice with that anonymity that he was talking about, so they don't look stupid, so that they can really say what they're thinking and what they're feeling. I think that possibly is a way forward. How we assess that, well, that's maybe where our next piece of research, you know, how can we assess authentic engagement in a way that is meaningful, so that we know we're going to end up with a competent professional.
And it's interesting, Stefania has said, I feel like student nurses don't have the time to enjoy their student period and have time to breathe as academic work and practice hours build up, and more pressure, especially on senior years when we're close to qualify, adding up OSCE and simulation practice. I mean, this is exactly, when you look at all the research about student nurses' experiences, is that they often feel, I'm thinking of the meaningful practice, is that they feel that they're still very much used as a pair of hands, that they're not necessarily getting quality learning in practice because they're constantly so busy, and then they're under pressure because they're having to do assignments and things like that. And like what you've said, Stefania, is this is still very apt today. And that's where, like I say, we as educators need to try and find a way to make that not happen, so that nurses, student nurses, do get some meaning out of their practice and learn.
The last kind of statement, because I know that we've gone over time, 24,000 more students in the UK, clinical areas. Imagine how kind of diluted the practice that we have got is going to be. So we have to come up with some other solution.
Thank you very much, Lynn and Louise as well for your comments. I think they were, I'm sure the attendees and the rest of the panelists found them incredibly useful. I would like to now introduce our final speakers, Dr. Susan Siebert and Dr. Ashley Carter. I will now explain each one individually. Dr. Siebert is a Doctor of Nursing Practice, registered nurse and certified nurse educator. Is a teaching assistant professor of nursing at the University of Southern Indiana in the USA. She teaches in the undergraduate nursing program and in the Master of Science in Nursing core courses. Her teaching expertise focuses on problem-based learning, interactive learning, coaching, critical thinking, and evidence-based teaching. Dr. Carter holds degrees in Doctor of Nursing Practice and Educational Leadership and a Master of Science in Nursing Education. A certified nurse educator through the National League of Nursing, Dr. Carter has more than 17 years of experience as a nurse educator and 25 years as a registered nurse. Her research focus centers on student success and teaching and learning strategies. Currently, Dr. Carter is an assistant professor of nursing at the University of Southern Indiana in the USA, teaching in the undergraduate and graduate nursing programs. The title of their talk is Strategies to Build a Resilient Nursing Workforce. And with that, Drs. Siebert and Carter, you may share your slides and start your talk.
Well, good day. We are very excited to not only be here, but end your wonderful conference. Susan and I are in Southern Indiana, and we're about 7 hours behind the rest of you. So it's quite early in the morning still for us, but nevertheless, we've enjoyed listening to the last few presentations, and it's just so interesting how our student challenges, our faculty challenges, our curricular challenges are felt across the world. There's a lot of commonalities that we've heard today, and we hope that our presentation will just add to the conversation as we discuss ways to help build a resilient nursing workforce.
So we'd just like to give you a clue of where we are. As the map of the United States here, we're located in what we call the Midwest, right in the red in the state of Indiana. Our university, the University of Southern Indiana, is located in the tip where the star is in the city of Evansville. Our region is known as farming. We have large exports in grain. We also have a lot of industry in this area because we're located on the Ohio River. Our nursing students enjoy access to 2 large trauma hospitals, a women's hospital, a state psychiatric hospital, multiple outpatient clinics, and a variety of rural health clinics.
Our university has approximately 9,300 students across our campus, and this includes bachelor's degrees all the way up to doctoral programs. Within our College of Nursing and Health Professions, you can see here, we've got a picture of our nursing students working collaboratively across other healthcare programs. Our current enrollment in our nursing program is about 850 students. We admit 180 students annually into our pre-licensure nursing program, where students are working towards becoming registered nurses and earning a bachelor's degree. Of our student enrollment, we also have a good portion of our program that's dedicated to graduate program as well, where we have about 300 students working on their master's degree to become nurse practitioners, And we have around 50 students currently working on their doctorates in nursing practice. Again, as I hinted with this picture here, our students work, and it's very important to us to give them the opportunities to work collaboratively with other healthcare professions. So within our college, our students do simulation experiences with students in occupational therapy, dental hygiene, dental assisting, medical sonography, radiology, informatics, food and nutrition, among other programs.
So here in the U.S., nurses enter the profession by passing their National Counselor Licensure Exam, also called NCLEX. Our nursing program has state and national prestige for our pass rates on this exam. So for the last 14 years, our pass rates have been 93 to 100% of our students pass this exam on their first attempt. Right now, we're tied for number one's pass rates in the nation. The national average for students passing this exam is 88% of the students in the cohort. And we credit our success by the quality of instruction, our authentic learning environment. We exceed the average on clinical hours, which is very appropriate. In the presentation before us, we have about 1,200 clinical hours that our students do in practice.
So our presentation today will walk you through a process for embedding resiliency building strategies into nursing coursework. Our established arc of previous research provides substantive evidence and theory for creating valid, relevant, and effective learning.
So as we aim to build this resilient workforce, we need to consider a theoretical framework. Because the goal of teaching resiliency is based on the need for resilient nurses in the context of a nursing shortage, high acuity patients, the increase in complexity and diversity of the nursing role, including the amount of travel nurses we have in our city. We need to situate the student learning to be transparent about what their work is really going to be. So situated learning is a theory that was envisioned by Jean Lave and Eddie N. Wenger in 1991. It's based on the theorem that people learn best in the environment and the context in which they are situated, which we have learned earlier in this conference. That community of practice framework's an offshoot of situated learning. And I actually created a concept analysis for a healthcare community of practice. And that's the theoretical framework in which we have built our resilience building teaching strategies. So before we try to transform our students into resilient nurses, we have to consider their learning needs. So we need to think about who is Generation Z, which is the students that we're seeing now in our courses. So Gen Z is that demographic group of people born between the mid to late 1990s and 2010s, following the millennials, but preceding the Generation Alpha. They're also known as Zoomers. I've provided some tips of the needs of this generation, that they prefer that real world authentic learning. They're technologically savvy. However, they crave feedback and validation, and they need growth and practice with critical thinking and practice with perseverance. This also aligns with other theorists like Malcolm Noe's adult learning theory and Kolb's experiential learning. So we have framed our resilience building strategies around problem-based learning. Problem-based learning includes that there needs to be a problem, a typical work-related issue or situation that's missing information. Because in nursing, it's never black and white. We never know exactly how our shift's going to go. So we need to present those type of situations for our students. Problem-based learning engages students in the exploration of resources. So we don't want to give our students all the answers. We want them to explore and discover on their own how to find the answers for that. Some of the problems or scenarios that would help a student develop resilience would be maybe a shift with multiple patients that all have priority needs, or a shift with an insufficient number of nurses staffed, or a pandemic situation with a limited PPE supplies. So something that would challenge the student into thinking, how am I going to tackle this? And in problem-based learning, the faculty role would be that of facilitator. So we don't want to be the sage on the stage and tell them all of the answers. We want our students to explore and discover the answers on their own. So if we think about Bloom's taxonomy, recall would be the lowest, most simplistic level of learning. And recall would be, I'm going to memorize what the teacher told me is the answer. And we want to promote higher level learning in our students. So we want them to discover the answers on their own. One way to do that would be to use like a Socratic style questioning and scaffold questions, asking them question after question that builds on prior knowledge and builds on the previous answer, where they have that aha moment and they discover the answers on their own. So employing both strategies of problem-based learning and Socratic questioning, we can help our students to develop that higher order thinking. So I've also put some bullet points here of how faculty can take on that role of facilitator. So I've developed and validated a teaching tool for clinical instructors, and this could be used in the classroom and lab settings as well, to challenge students to think and to take on a problem and discover answers. So this tool includes some questioning prompts that can be used. The questions are leveled by Bloom's. What you don't see on the flip side of this is also questions that are ordered around a typical nursing routine, like getting shift report, what to think about after you've assessed all your patients, after and before giving meds, etc. And this, what you see here, is organized around the elements of critical thinking. So it's a tool that is validated that faculty and instructors can use to help students with a problem in situated learning.
So we know resilience involves adapting to and overcoming stressful life circumstances. For our students and yours, resilience is needed as they encounter challenges within their student role, and we certainly know it'll be necessary as they transition into the role of the professional nurse. This, as we've all lived through the COVID experience, was never more evident. And we still see lingering effects of the pandemic in our nursing workforce, with nursing shortages, high rates of burnout and compassion fatigue within the U.S., and increasing acuity of our patient population. At the height of COVID, it was estimated about 52% of our national workforce intended to retire or leave nursing. Even more concerning was a report that about 46% of nurses under the age of 25 reported being not at all emotionally healthy, and about 40% of nurses with less than 5 years of experience as a registered nurse also reported not being emotionally healthy at all. While our projections in the U.S. note that now we have about a 20% rate of new nurses leaving the profession annually, we continue to have grave concerns about our workforce's mental well-being. We believe nurse educators can work with students to help build the resiliency by adding competency-based active learning strategies into the curriculum. Interventions enhancing resiliency should be individualized to each student, thereby motivating and encouraging the student to continue the activity. Highlighted on the slide here is work that we did revolving around what we called the Student Nurse Resiliency Project. And this was a semester-long project that required our brand new nursing students to select 3 evidence-based strategies to build their own resiliency. Students created a plan for themselves to utilize these strategies over a period of 6 weeks, and then they reflected upon the success of their plans, the barriers they encountered, and wrote this in a writing assignment. Faculty prompted additional student reflection by asking students to describe how they felt resilience would impact their future careers. This was a problem-based learning approach requiring them to reflect upon the stressful work environment, observe team behaviors, and acuity of patients while navigating their new practice role and learning to find that work-life balance. We know resilience allows students to help them learn and to grow in their roles, which is necessary for their health and professional development. And this attribute will help them bounce back from those challenges that are inevitably going to occur and those failures with a mindset that they can push through those situations. So in our study here, you can see on this slide, we've highlighted some strategies that the students told us they preferred to build their own resiliency. And those included things ranging from mindfulness, stress management, exercise, and self-care. Additionally, our work evaluating this strategy with our students revealed some insightful comments. We found in the reflective writing, those comments really gave us information on how they felt they could maintain their resiliency in their future roles and what they needed in order to maintain that healthy balance of their physical and mental well-being in their new roles within those high-quality patient care settings. We learned their intentions to continue using these strategies, and they described these strategies as protective factors for their well-being. Students identified resiliency. One student noted as the vehicle which we can ensure our attention stays focused on what matters. Another student told us that it helped them to develop the necessary skills to continuously provide caring, compassionate, and effective care to their patients. And another said, patient outcomes will ultimately be better. The nurse will have better mental health, and there will be a better team morale. Growth mindset, grit, and resilience also help to build a resilient workforce. While the previous activity helped our students see why they must believe they can be resilient and how to grow their resiliency, this article here highlights a teaching strategy I created for 5-minute pearls to help them grow their own growth mindset. We worked with our students to build that growth mindset because we knew evidence told us in the literature that it not only increased their student success, but it also helped to create a positive mindset that would allow them to embrace opportunities for new learning and growing, but to also view failures as learning opportunities. Carol Dweck's work on growth mindset tells us that with persistence and effort, growth-minded individuals can improve their knowledge, skills, attitudes, and abilities over time. For our nursing students, and probably yours as well, this takes on the mindset of I haven't learned a skill yet, or with deliberate practice, my performance can and will improve. We can see how this attribute is also essential in our workforce. So essentially, this activity was a series of 5-minute activities introduced at the start of a class time over a period of 10 weeks. And we found short YouTube clips and faculty-facilitated discussions on topics ranging from growth versus fixed mindset, self-efficacy, positive affirmation, neuroplasticity. We also spent time on ways to reframe setbacks, set goals, persevere, and prioritize their learning. Students were encouraged to build their growth mindset, and at the end of the semester, we asked them to write a 1-minute reflection paper about these activities and identify their current mindset for us, and tell us what they liked, which strategies worked. We received overwhelmingly positive comments from our students about these brief lessons, in that they said it helped them during their first semester of nursing school, but perhaps more importantly, it also showed them that how these intentional activities to support their success also conveyed how much faculty cared about each student's success and their well-being. So we've highlighted here some themes that emerged from the strategies that our students reported worked best for them. The first was a refocusing mindset, and activities for this included things such as reframing setbacks, such as focusing on the process instead of results. I think we heard about that in a previous discussion. Being open-minded by not comparing oneself to others, and having a positive attitude or using positive affirmation again to engage in positive self-talk. Striving for competency also emerged as a theme, and those activities included things related to developing those needed knowledge, skills, and abilities for nursing students. So our students reported that they developed better study skills or identified ways to make the needed time for deliberate practice. Some students reported being more actively engaged in the classroom and making a point of asking questions during lectures, or being more actively engaged in skills lab to work on achieving their competencies. Prioritizing self-care was also noted. Yoga, mindfulness, meditation, getting adequate rest, and taking breaks were all things students discussed. We also had students that engaged in reflective practices. So, guided journaling, debriefing, guided reflection were things that students noted as helpful. And finally, our students really, resoundingly said engaging in social support. So working with peers, creating study groups, trying new things with peer support. Again, back to the comment in the last talk, where students really sometimes don't have the time to enjoy the learning and enjoy each other and enjoy the process. So definitely, again, engaging in that social support. As faculty, we also identified another theme, and that was enhancing their time management skills. This was an area certainly our students needed help with, and we as faculty encouraged the use of calendars or daily planners, and stressed the importance, almost giving them permission to make time to prioritize self-care for themselves. Our newest project involves affective learning, and we're excited. We just got news yesterday that we'll get to speak on this topic nationally at our National League for Nursing conference in the spring. Most faculty we know, and you might agree with this, most faculty tend to focus on evaluating cognitive and psychomotor domains of learning. However, finding a measurable way to evaluate effective learning allows faculty to know if students' feelings and beliefs are integrating core nursing values. Mm-hmm. The effective learning domains involve the human experience of emotions or feelings, the degree of acceptance or rejection of values or beliefs, and a person's interests, motivations, or biases, or their attitudes. Resiliency is certainly an affective competency. So looking at Krathwohl and Bloom's taxonomy, again, going from that simplest to complex, at the lowest level for acquisition of effective skills, students need to demonstrate an ability to receive information, and then they move into a responding to interact, valuing such responses, organizing their values, and then finally internalizing or committing values to practice. So we intentionally designed activities for our new nursing students over the course of their first semester in the nursing program to focus on affective learning. Along with resiliency and growth mindset activities that we've discussed, we also created other activities to focus on professional communication skills, ethical comportment, cultural humility, moral reasoning, and caring behaviors. Again, all core nursing skills and values. In our final writing assignment for this course, we asked students to write their nursing philosophy, looking at that paradigm, and clarify their values and beliefs. And on the last day of class, we also asked them to complete a new tool that we created, looking at the effective learning self-reflection. For this activity, the students utilized the Krathwohl's taxonomy and self-selected their perceived levels of effective growth over the course of their first semester of nursing school. While all of our students achieved level 1, receiving information, more than 90% also identified achieving level 2, and about half of our students achieved level 3, or that valuing. So I think we would all also agree that faculty play a role in helping our students form a professional identity. Activities to build grit, resilience, and growth mindset must be introduced early in the curriculum, and this supports their affective learning and role transformation. There's been more topic or discussion of professional identity in literature in recent days, and you can see here the definition of professional identity. But we have a study by Owens and Denny in 2023 that aligned with Godfrey and Young's definition here that you can see. And they reaffirmed that nursing students learn about common definitions of a professional identity in nursing early in the curriculum in order to help guide them in their thinking, acting, and feeling like a nurse. So here we've highlighted professional identity encompasses 4 areas, and those include values and ethics, nursing knowledge, that all nurses should be leaders, and professional comportment. Students learn about professional identity by observing the behaviors of other registered nurses, including nursing faculty. And this type of situated learning can be difficult for faculty to control. The greatest barrier for our students to grow in their identity is that unanticipated expectation of them. We need to be transparent about the role and help relinquish preconceptions and misconceptions. After completing the effective reflective assignment, one student wrote, "I had a complete misunderstanding of what the nurse was." And this is an excellent example of how we need to correct their thinking early in the curriculum to, again, help form their professional identity and their resiliency. So Gottfried and Young also provided us some comments on how to identify some other strategies to help our students integrate a professional identity. And they include things such as getting students to understand their role in hearing expectations and accepting advice for success. Students need to value feedback from others, engage in reflection, label what nurses do with standards for care, and see how that aligns with the nursing's purpose and impact on patients. Students must learn how to take ownership for learning, build relationships with others, develop self-care habits, and embrace opportunities for experiences with with patients. And that includes even experiences in a simulated setting. And I think that, all of these strategies that I've just stated here are all things that not only do we say students should do, but it's things that faculty should help them do as well. Create time and space for them to understand the importance of those strategies. So we think you can see today in our presentation and kind of tying together all the other presentations from today, we have a lot of, again, commonality in our work and our goals to build a resilient nursing workforce. We've discussed today that with intentional design of activities, we not only can help students to begin to develop their professional identity, but also help them to become more resilient members of the workforce. We understood the learning needs. We created activities that were in context. We served as facilitators of their learning, engaged students in application level learning, repeatedly provided opportunities to reflect, and assisted our students in integrating a professional identity.
So we are very interested to know if you employ resilience building strategies in your programs, in your coursework. If you could post in the chat that your examples of how you do that. And we want to make sure you know that any questions that were not addressed, feel free to email us. We have our contact information here. We'd love to hear from you.
Yeah, and like the previous speaker, and I imagine others as well, we're excited today to be on an international platform and to meet new colleagues. And we welcome the opportunity to work collaboratively because, again, I think we all share the same goal for our students and our workforce and our love for our students and what we do. So please reach out to us. And again, if you have any questions, we welcome the opportunity to engage with you. Thank you.
Thank you so much, Susan and Ashley. That was really interesting. We do have time for just one question. So we got one on the chat. Resilience and well-being is mostly challenged by night work when there is the least support and competing demands leading to burnout in healthcare professionals. What can you offer to enhance well-being for night healthcare workers?
Wow, that's a great question. I think it has to come from management as well to commit to recognize that the stress the workload, the extra challenges that occur on the off shifts, for sure. I've heard examples of having a quiet room with massage chairs, a yoga mat, allowing nurses time to take step off the unit and take those few minutes, ensuring that those off-shift workers have time for meals, and also having a community of practice within the night shift so they could share experiences amongst each other.
So thank you so much both for that. It was a really, really great answer. I think now I'd like to hand the mic over to Louise, who'd like to say a few words before we close.
Okay, well, first of all, obviously, I'd like to thank you all for some amazing presentations, and like you've said, Ashley and Susan, about how we can all resonate with all of these topics, even though they've been very different topics. They're all very similar, and I'm sitting here thinking, and I'm sure everyone else is sitting here thinking, oh yeah, you know, that's so apt for us and our country and our nurses and our students, and I'm certainly, and I'm sure a lot of everyone else in the room are thinking, we need to do that. We need to do that in our curriculum and our program. So I mean, I like particularly about the 5-minute pearls. You know, I shall certainly be talking to the team about that, and just looking at the different strategies for resilience. And you asked the question about what do we do, and I don't think we necessarily do anything formally. Obviously, we're there for our students, and we're you know, we go out to see them and we talk about how they're developing their own personal resilience. But I think it is something that we need to look at. Certainly in Gibraltar, is about how we can develop students to think about developing their own resilient strategies. So and some interesting statistics in America. And again, going back to Lynn's, you talked about the sort of the practice and the hours. I mean, obviously America had the smallest amount of hours, didn't it? And it's interesting about what makes a good nurse, you know, what makes that nurse, like, you know, is it NCLEX? What used to be in my back in the day was the CGFNS. Do you remember that? Well, it's the NCLEX thing now, you know, about how we assess the nurses' competence and clinically, but we're not really looking at their you know, the affective domain, about their values and professional values, and you know, how they care, or do they have that person-centered caring? Do they care like we did probably when we trained? And it's interesting what you said, Lynn, about, you know, we trained roughly at the same time, about how we all lived in the nurses' home together, and that was our community of practice, wasn't it? That was where we would come home at the end of the day and sit and talk about things. And obviously from my study, that my students talked about that, the importance of that peer reflection and discussion with their colleagues, the other students. But obviously it's not easy for them to do that, because now our students are so different. The demographics are all, they're married with children, grandchildren even. And so they don't have that nurses' home to go back to. And
it
so
goes
the only
back
time...
to Neil's word authentic, doesn't it? For us, it happened very authentically,
yes,
very naturally.
And we have to make sure that we can facilitate that.
Yeah.
But of course, it's difficult at work. And the question about the night shift, you know, people think, oh, the night shift, it's easy, it's quiet, you know, they can have more chance to chat and everything. But I mean, it's interesting about, you say about the community of practice within the night shift. I think that's actually the night shift team. I think we do, as nurses, generally have that community of practice, just, you know, the way that we do communicate with each other. But just some interesting points that I can certainly resonate with. And again, with Neil's session about his presentation, there's so much that person-centered care that I think we need to think about embedding into our curriculum. And I was thinking about Healy's, you remember, Lynn, back in the day when we worked together about the creating a curriculum that's a research-informed curriculum, and Healy did some work, Healy et al., on that, and how research was completely embedded in every single module throughout the whole program. And there's no reason why that can't be embedded into the curriculum, person-centered care, affective learning, all of those things that we've talked about today. And sustainability, Heather's session, I mean, I know for a fact, because I'm an external examiner at Brighton, is that they actually have a module that is linked to sustainability in healthcare, and that again is something that when we review our programs, our undergraduate programs, even postgraduate programs, that's something that perhaps is a module that we could perhaps look at and write with Heather, and because it is something that we all need to be thinking about, isn't it? Making practice sustainable, as you said, Lynn. And obviously, the deception, the concept of deception that Guillaume talked about. To be honest, when he first mentioned it, I was like, what does he mean by that in simulation? Because I did a study at master's level all about simulated practice and how it prepares student nurses for practice. But this concept of deception in simulation is not something that I'd ever really thought about. So that's something, again, that we need to think about as we are developing. The University of Gibraltar are developing our own brand new simulation suite, which we've got a whole floor of a big building, so it's going to be amazing. And so all of these concepts and ideas that we're going to take forward. So I hope, certainly for me, I've resonated with a lot of things, and I'm hopefully everyone else here, all the attendees and the presenters, have hopefully taken away a lot of the ideas that they can perhaps take back with them to their own context. So finally, I just really wanted to thank everyone again for taking time out. I know that you're all very busy. I've certainly learned a lot from you all today, and I really hope that we can develop some collaborative research. I mean, I'm sitting there itching, thinking, oh, good, we could do this research, we could do that research. So I think there's going to be a lot of research coming out of this, I'd like to think. So thank you very much. Has anyone else got anything that they'd like to say, any of the presenters?
Susan and Ashley have their hand raised.
Yep.
I was just going to add that the concept of resiliency and why we started building that in our program was brought forward by our practice partners. So we have an advisory council of nurses from all of our clinical settings, and we always ask them, what can we do differently? How can we improve our curriculum? And they brought forward that we need resiliency built in, because the newer nurses just would fold under the high acuity of the patients, and just not that they weren't trained how to be a nurse, but how to sustain within the nursing profession. So we used our community of practice as our advisory council to kind of come up with that idea of what we needed to do to embed resiliency in our program.
And I quite like the three things that you mentioned about, the yoga and the eat it healthy diet and things like that. And that's, again, something that my mind's ticking over now, thinking we could do that. So yeah. Lynn, is there anything else you wanted to
No, I just want to say it's been an absolute pleasure. And I do think there was, whether it was intentional or not, there was a really great central thread that ran down
the golden thread.
Talk about that golden thread and how you pull it through to give something its kind of wholeness. And I just felt today, from that point of view, it was very good. It was a good experience for all. So thank you. I've enjoyed everybody's presentation today.
And it doesn't matter where we are in the world. I think some of the problems just are the same. As you talked about the common problems, Susan and Ashley. These are problems for nursing globally, aren't they? So whether they get better over the years, we don't know, but we're working on it, aren't we? That's what we're doing. We're working on it. So thank you very much, everybody. If there's no other questions, was there anything else, Leon, before we wanted to go?
Yeah, no, I just wanted to say, before we officially close, that I wanted to thank all of you, all the speakers, those which are present and those which have left, for giving your time and giving us your, sharing your research with us. Of course, wanted to thank our attendees for listening to our speakers today, and last but by no means least, I'd like to thank Dr. Louise Lawson and Dr. James Vinales for putting together such a fantastic panel of speakers. And I also wanted to mention Ivana May for all her administrative assistance. It really helped with the smooth organization and running of the conference. So that's really all I wanted to say.
We couldn't have done it without
closing.
you, Ivana. Thank you.
Yeah, it was great. So yeah, I think with that we can close.
Great. Well, keep in touch, everyone, and we'll certainly get together for some ideas in the future once the new semester is up and running. And
so great to meet everyone. Look forward to the next time.
Yes, absolutely. Thank you very much, everyone, and thank you to all the attendees again. Just click on the leave in the right-hand corner, and that's how you leave the room. Thank you. Bye. We finished.
We did it.
Yes.
Oh.
It was good though. It was quite interesting.
It was. I'll come up.
Yeah.